growing very fast in terms of death and incidence. When Chinese patients are diagnosed, the PSA levels are very high. So we must have better treatment for prostate cancer. Kakago and Cisco PC, with their support, in 2023, we have launched a project to improve the treatment of prostate cancer, to respond to Healthy China initiative, to provide more scientific and better treatment. We want to launch this program to bring better treatment to prostate cancer patients. We want to reach this consensus and to carry out standard treatment. We want to cover more hospitals and carry out full cycle standardized treatment. We have hosted over 1,000 meetings, participated by over 10,000 doctors in urology. We focus on evidence-based medicine. We consider Chinese clinical cases. We receive support from Kakago, 7 experts and 7 writers and 50 editors jointly worked on the first expert consensus on prostate cancer management. This will contribute to individualized treatment and precision diagnosis and treatment. This is also an innovative model for multidisciplinary treatment. This will improve the benefit and quality of life for the patients in China. Now, let's invite Professor Ye Dingwei, Shi Benkang, Xing Jingwei, Zhu Shaojing, Zhang Zouqing, and Professor Huo Hongming to the stage. Let's jointly release the expert consensus on comprehensive management of prostate cancer patients in China. Please put your hand on the screen. Let's count down. 5, 4, 3, 2, 1. Now we have officially released the expert consensus. Thank you, and please take your seat. Here we also thank every doctor and expert in the process. I believe that the release of this consensus will provide a lot of support to urologists and will safeguard and the standardization of diagnosis of prostate cancer in China. Now is the launch ceremony of the standardized diagnosis and treatment improvement project of advanced urethroepithelial cancer. 220,000 deaths, bladder deaths, death in China 43,000, incidence 46%, greater than global average, 5-year survival rate less than 9%. Patients need new treatments to open a new era. We have this targeted medicine that targets the lesion and it destroys tumor cells and improves the life of patients. Compared with chemotherapy, the numbers have improved. You don't need testing. It's very controllable, very safe, and we have pulled the experts to fight against the tumor. Ventuzumab is very important, and we congratulate on the approval of Ventuzumab. This will contribute to the patients of UEC patients in China. This will improve accessibility to clinical centers. Congratulate on the launch of Ventuzumab, and The patients with advanced urethral epithelial cancer will benefit from this. This will bring better treatment to the patients. It will break the bottlenecks. It has been recommended by guidelines from around the world. It will promote standardized treatment and create a new era. Professor Ye Dingwei, Professor Ding Qiang, Professor Xia Shujie, Professor Zhang Aili, Professor Jing Baiye, Liang Chaochao, Zhang Dahong, Pan Tiejun, Liao Hong, Zhang Xiaoping to the stage. Let's jointly launch the standardized diagnosis and treatment project for advanced urethral epithelial cancer. Let's count down. 5, 4, 3, 2, 1. Let's launch. And thank you. Please take your seats. The standardized diagnosis and treatment project for advanced urothelial carcinoma is committed to innovation. It provides patients with more scientific and efficient treatment. Next is the release ceremony of the Prostate Cancer Diagnosis and Treatment Science Popularization Answer Book. Prostate cancer is the second killer for men. The patients are many and the incidence and death rates are rising.
Behind every data, there is a life that is waiting to be saved. Over the past several years, as medical technologies have been evolving, we are now seeing new diagnosis and treatment tools. Prostate cancer treatment has set up a whole process management. This has greatly enhanced the living conditions and the quality of life of patients. This has also promoted, or we will try to promote the popularization and democratization of knowledge of prostate cancer. That's why we set up the guidelines and implementation workbook. The KAKAGEO will be setting up an expert committee to promote the development of the popularization of a prostate cancer knowledge answer book. The clinical experts in the prostate cancer field has pulled their wisdom to light up the future for prostate cancer patients and to write a new chapter in the popularization of the knowledge of prostate cancer in the future. Now let's welcome to the stage Professor Ye Dingwei, Li Changling, Shi Bingkang, Xin Jingchun, Zhu Shaoxing, Zhou Qing, Jiang Junhui, Wang Xiaoling, Zheng Hao to the stage, the editors of the Prostate Cancer Diagnosis and Treatment Popularization Answer Book. Experts, please place your hands on the corresponding position on the screen. Let's count down together. 5, 4, 3, 2, 1. Congratulations on the Prostate Cancer Diagnosis and Treatment Science Popularization Answer Books release. Thank you all, experts. Please take your seats. This popular science book fully utilizes the professional advantages of experts and scholars to explain the complex knowledge of prostate cancer. It's presented to readers in the form of easy-to-understand questions and answers, which will help patients to understand the prostate cancer disease, master the management methods of the disease, which will improve the overall treatment effect of the patients. UC is a common malignant tumor in urinary system. It has a high recurrence incidence, but experts are committed to finding new treatment options to improve prognosis and quality of life of patients. Checkmate 274 and Checkmate 901 are the two leading breakthroughs in immunotherapy for UC. Now let's see a video to see the two important milestones of the research to together lead a new chapter in UC immunotherapy. Let's welcome to the stage representatives of this trial, Professor Ye Dingwei, Professor Li Changling, Professor Zhou Qing, and Professor Chen Hui, Professor Dong Haiyang, Professor Zhang Peng, Professor Sun Zhongquan, Professor Qin Mingxing to take the stage to witness this historic moment together. Let us take a group photo. Thank you, everyone. Please take your seats.
下面有请摄影师台为大家合影。
Now the photographer will go on the stage to take a big group photo for everyone.
好的，开幕式
The opening ceremony is concluded now. We will move on to the academic exchange session. We have prepared simultaneous interpretation for everyone. Professor Li Qiangling, Professor Xia Shujie, Professor Ding Qiang, Professor Liang Chaojie will be hosting the first round of academic lectures for us. It's a great pleasure to be moderating this academic session with Professor Xia Shujie, Professor Ding Qiang, Professor Liang Zhaozhao. In this session, we have invited two academics to make presentations. The first one is the chairman of this forum, Mr. Ye Dingwei, Professor Ye Dingwei, whom you all know very well. He has greatly contributed to the development of urological oncology, and the team that he's led has designed top-level planning and has a long-time commitment to urological oncology field, which has achieved great progress and achievements. So this topic is from clinical research to guideline consensus, innovative path for diagnosis and treatment of urological tumors. I will not dwell on the long CV of Professor Ye Dingwei. Without further ado, let's welcome to the stage Professor Ye for his speech. Thank you, Professor Li Qiangling. Now I'll give you a presentation themed on from clinical research to guideline consensus, innovative path for diagnosis and treatment of UT from Fudan University Cancer Hospital, Department of Urology. Let's look at the Shanghai statistics first for the urinary tumors. The highest increase for prostate cancer and the highest cost for bladder cancer, and the younger and younger trends for renal cancer patients. These are the three trends for the Shanghai patients. We have full process management, and the second one is surgical surgeries, and third is comprehensive management. These are our three levers. In terms of clinical research, even though the treatment effect has been improved, but there are also unmet demands. Thanks to clinical trials, we will continue to break through the plateau and to further enhance the clinical effects. First, let's look at diagnosis and identification. Over the past 20 years, the Fudan Cancer Center has set up a platform for systematic diagnosis and screening for prostate cancer. We have a clear identification and screening. It's very important. For the European system, European and American system, the PHA and PSA identifiers, the screening, the detection rate is quite high. But the PHI and PSA are not really suitable for Chinese people. Some academics have also mentioned that PSA is really based on westernized indicators and standards from the Europe and America. So detection rate is low, and there's an over biopsy and puncture rate and a waste of medical resources. So based on the KKGO, we have set up the first edition of the expert consensus on screening of prostate cancer. So we have a prostate cancer precision screening base at the regional level and also at the community and residential community level. so that we have made a lot of explorations in terms of the biomarkers that are suitable to Chinese people. The PHI indicator has been discovered, and we have set up this PHI-based prostate cancer screening scale for Chinese people, which has greatly increased the detection rate and screening rate for PSA. So we have also won the Gold Award of Shanghai Excellent Invention. And with AI technologies emerging nowadays, we also want to embrace AI technologies. So we are now entering into an AI algorithms era from the sole reliance on biomarkers. We can get biopsy and pathological materials and data, and we use AI to enhance the screening and identification of prostate cancer. The team members have also set up this deep learning algorithms plus urine multi-omics. So it's a UC diagnosis model. So in the past, we relied solely on omics, but now we have added an AI model which has enhanced the precision rate and the stability and efficiency of the diagnosis. Furthermore, we have set up multi-center clinical trials, so we hope that through trials we can enhance the translation of products into a reality. For example, the in vitro diagnostic model for UC, this is the early screening study. The efficacy is better than clinical application detection methods such as urine exfoliative cytology and FISH. And this is published in Molecular Cancer Journal, and it has gained a lot of recognition, and it is widely covered by the Wenhui Journal, Xinmin Evening Journal, etc. Through trials that we can help the translation of various innovative products. So for example, the detection kit, human FGF3 TRT gene mutation and 1cut2 of VIM gene. This combined detection kit has been approved by the NMPA for Class 3 medical device registration. It is also recommended by authoritative guidelines such as the 2024 CSCU, UC Diagnosis and Treatment Guidelines, Experts Consensus on Early Diagnosis and Treatment of Bladder Cancer 2024 edition, etc. In terms of AI algorithms, we have also additions to AI algorithms with imaging pathology and to enhance efficacy. And we have done a lot of new works. Through AI algorithms, we can predict, through MRI, we can predict the pathology of oncology of tumors. And our experiences have also been published. Second, surgeries. This is the basis and the foundation of the capacities of surgical doctors. In the past, we do open surgeries. We don't even the vision is very poor. My professor, I remember that I was doing surgeries with my mentors when I was young. We cannot see anything. Our foreheads would be bumping together. And then laparoscopic surgery all the way to robotic-assisted surgery with better visions. So over the past 10 years, our prostate cancer surgery number has been increasing. As of November 2024, according to Shenkao statistics, the prostate cancer surgery number has been ranked #1 in Shanghai. The Fudan techniques of prostate cancer with innovative precision, with a very precision-based anatomy, pelvic anatomy, has been very famous. Now we are entering a new era of 3 machines with the Da Vinci robotic surgery system, 2 systems of Da Vinci, and 1 Ryzen novel robotic surgery system made in China. And there's a modulative robotics, surgery robotics. In terms of surgical operations, a lot of our techniques we learn these techniques come from our foreign colleagues, open surgery, anatomy, and as we enter into robotics era with Dr. Patel in June this year, he has completed 17,000 robotics RPs, and we cooperated with him and established the Shanghai Urological Oncology Institute Robotic Surgery Innovation Center. I was also hired as an honorary member of this center, and we also, as the leading PI, we started the multi-indication clinical trial of Haishan 1. We have successfully completed the human clinical trials using Haishan 1, and it's been submitted for approval. In 6 months, it might be approved. So this is the first modular robotic surgery made indigenously made in China. You see that there are various arms, and you can pull these arms to everywhere you want. And this is quite immersive vision compared to with Hugo CMR robotics, where you need to wear a pair of glasses. It's quite different. It's more suitable to us who are already familiar with the Da Vinci surgery procedures. There's also a direct arm. This means that you can take down the periscopy arm and install this arm onto the Haishan robotics, and it can be fitted and used. So sometimes you don't need the full arm robotics. You just need to do some dissection, and you can use this modular arm. So for the radical prostatectomy and also for these experiences have been published in the International Journal of Surgery, the partial nephrectomy research. As with the advent of robotic surgery, we hope that we can further promote the use of these tools with the general democratization of these equipment. For example, the Haishan 1, which is compatible with the laparoscopy with existing vision systems. So with the Olympus stores, a lot of community-based hospitals, the grade 2 hospitals, they've already had laparoscopies, and then if you equip it with one additional arm, then it can perform Haishan surgeries. And then we will move into a precision-based stage where you have a 3D high-definition laparoscopy supporting the fluorescence function. And then at the intelligence stage, at the third stage, we hope that we can have AI addition and tissue recognition, intelligent navigation with perfusion imaging, tissue recognition, tumor boundary recognition, etc. This is in the development of exploration, and we are now in this stage, so that from better vision to precision-based vision and to better surgeries, there's still a lot of room for growth. Third, comprehensive treatment. Going forward, we hope that we can enhance the 5-year survival rate. This comprehensive treatment is critical to this objective. We are now in the precision treatment stage. It's different from the simple multidisciplinary treatment. So multidisciplinary research has launched a very solid foundation for comprehensive treatment for UC and prostate cancer, renal cancer. In 2021, we are the only Asian team that was invited to launch a review on the Nature Reviews Urology, outlining precise classification and treatment of prostate cancer in Asian populations. In 2024, our team was invited again to publish in Nature Reviews Urology, outlining biological characteristics and mechanisms of prostate cancer, liver metastasis, and diagnosis and treatment strategies for liver metastasis. This has gained a lot of recognition for international peers. For clinical trials, for UC, from the metastatic castration-resistant prostate cancer, all the way to the first line to third line treatment, PARP inhibitors, AKP inhibitors. All these are on the urology oncology. We now have 37 trials ongoing, and our chart research was published in ASCO 2022, and this research is also launched in the Lancet Oncology. So this multicenter phase 3 clinical trial is on the Chinese solution for enhanced endocrine therapy, 54% reduction in the risk of radiotherapy progression. So this is included in. It was approved in 2022 and was included in the medical insurance scheme in 2023, benefiting the Chinese population. So in the future, we will continue to do more explorations. We have published in the Med journal the correlation analysis between PSA response and long-term prognostic endpoints in the chart study. It was published in Med for new type of endocrine research. This is a very good signal. The PSA has been reduced to a certain level, and this might be a good marker for prognostic endpoints. Recently, our research was accepted. Compared with bicalutamide, compared with ADT, rivalutamide compared with ADT can significantly delay the progression of pain and improve the quality of life of subjects. It was accepted by STTT with an influence factor of 40. And also together with innovation companies, we have launched the ISMO 2024. We have made a 10-minute speech on the metastatic UC with the BLBO1D1. And also in 2024 ISMO, the EGFR HER3. There's a second-line treatment of previously treated UC patients. The phase 3 trial will be beginning soon. And fourthly, all these experiences will be included into a clinical consensus. So the research results have been included in the guidelines for integrated diagnosis and treatment of tumors in China, and also the EAU guidelines and NCCN, and also the APCCC consensus on cancerology. And on behalf of mainland China, I participated in APCCC consensus meeting for several consecutive years, and in 2024, I made a keynote speech, and I was elected as the only representative of the mainland China as an IBCG representative. And also, I was invited to participate in the Advanced Professor Cancer that St. Gallen Consensus Conference. I was a representative of IBCG also. And also, I am the chief editor of prostate disease in the new edition of Wu Jieping Urology. And in terms of a precise classification and diagnosis and treatment strategies for advanced prostate cancer, this achievement has won the first prize of the 2024 China Anti-Cancer Association Science and Technology Award, which is the biggest award for prostate cancer. So the overall survival rate has been improved with all these efforts. Prostate cancer survival rate is domestically leading, and Compared with the 69% of survival rate in the US published by Lancet, we have reached 74%. And for kidney cancer and bladder cancer, the survival rate are on par with Europe and the US. And also, drugs and machines are equally important. All these new drugs that were launched and all those medical appliances. We have a large-scale medical appliance such as the Haishan One, robotics, and also surgical robots, and we will continue to enhance the techniques of surgical techniques. For example, the Fudan Oncology Center techniques will continue to be honed, and for comprehensive management and treatment, we'll continue to promote multidisciplinary cooperation, and we will be anchored in multidisciplinary diagnosis and treatment with a carpet-style coverage of new targets to find a way out for patients. And we will also learn new standards and apply new standards and formulate new standards. With the clinical trials, we will actively break through the plateau. And I would like to thank the support from all my team. Thank you.
Thank you, Professor Ye Dingwei, for your very excellent keynote speech. You talked about basic research and consensus writing. I think he has three features. First, very forward-leading in his innovation. Second, international. His clinical research and his theses are very influential internationally, and also very practical. Clinical research and basic research are transformed into medical devices. Let's once again thank Professor Ye. Our next speaker is Professor Declan Murphy. His topic is pelvic lymph node dissection now dead?
Declan Murphy，大家欢迎。
Good morning, Ni Hao. Thank you so much to Professor Ye and the organizing committee for this prestigious invitation. It's been more than 5 years since I visited this beautiful city, this beautiful country, and I'm so happy to be back again, learning from you, my friends and colleagues here in China. So Professor Ye has asked me to discuss this topic. We're all urologists. Everybody loves doing pelvic lymph node dissection. It used to be my favorite part of the surgery. But now we wonder, what is the role of pelvic lymph node dissection? So I will share with you today my thoughts on this. This is a scene from my home country in the west of Ireland. Even though I live in Australia, I'm from Ireland. This is a beautiful sunset, and this is my conclusion. I believe that the sun is setting on pelvic lymph node dissection in 2024. I'll talk about the role of lymph node dissection in patients with no evidence of lymph node involvement on scanning, in patients who do have evidence of lymph nodes on scanning, and finally, briefly, the interesting area of PSMA radio-guided surgery. This year at the EAU meeting, we had a big plenary session on pelvic lymph node dissection, which I was involved with. They presented this typical case of a young patient, PSA 17, PIRADS 5 lesion. He had a biopsy revealing Gleason 8, grade group 4, prostate cancer. So clinically significant cancer. He had both CT bone scan and also PSMA PET-CT showing no evidence of cancer outside the prostate. They calculated the nomogram, Briganti nomogram for lymph node involvement, and estimated 23% likelihood, and therefore a pelvic lymph node is recommended in the traditional EAU guidelines. He had his surgery. There was no evidence of any lymph node involvement on the lymph node dissection, 20 lymph nodes, and there was a positive surgical margin. His PSA was persistent after the surgery, and he did have a complication of the lymph node dissection. He had a large lymphocele requiring laparoscopic fenestration. Finally, he went on and had radiation therapy, and he's doing well indeed. This year, we have seen a big change in the EAU guidelines because this example was in the era of the traditional EAU guidelines. If we look at the traditional nomogram for this same patient, yes, the predicted lymph node involvement is 23%, and the EAU guidelines before this year would strongly recommend extended pelvic lymph node dissection. However, there has been an updated version of the nomogram published last year, which includes PSMA PET. So this patient had a negative PSMA PET. And if you include this in the nomogram, the updated nomogram, the predicted lymph node involvement is 3%, not 23%. So clearly, PSMA PET is a very powerful tool we can use to help predict who needs a lymph node dissection. And this year, the guidelines changed significantly, as I'll mention to you. They no longer mandate pelvic lymph node dissection for high-risk disease. They say, if you're going to do one, make sure it's an extended pelvic lymph node dissection. And I think this is my important statement for you, that there remains no evidence that a pelvic lymph node dissection improves survival in prostate cancer, and plenty of evidence that it causes complications, as we see here. So in this case, this is the question we ask at the EAU. Did the pelvic lymph node dissection help this patient? No, it did not. The patient had negative lymph nodes and required radiotherapy anyway and got a complication. And ladies and gentlemen, I think that is a very typical experience of pelvic lymph node dissection. So in the previous guidelines up until now for intermediate risk prostate cancer, the guidelines said, do an extended pelvic lymph node dissection if the predicted nomogram says greater than 5%. That means 95% of those patients will not have any lymph node involvement. And for high-risk cancer, it said, do an extended pelvic lymph node dissection. But this year, the EAU guidelines, which I know many of you follow, and we follow in Australia, have dramatically decreased the emphasis for pelvic lymph node dissection. This is the section of the EAU guidelines for pelvic lymph node dissection for intermediate risk prostate cancer. You can lift up your camera and take a photograph. This is what the EAU guidelines say about intermediate risk prostate cancer. Nothing, no mention. It has completely disappeared. No discussion about nomograms or PET scans, just no recommendation to do a pelvic lymph node dissection. For high-risk cancer, it's not mandatory. It says if you are doing one, make sure you do an extended lymph node dissection. So this is a very big change in the world's biggest international guideline. And we've been talking about this on Twitter and elsewhere. And I have to say that this now aligns with our practice in Australia, where we use a lot of PET imaging for more than 10 years. And we really have stopped doing pelvic lymph node dissection for very many of these patients. If you're interested in hearing more about our thoughts on the EAU guidelines, we publish a podcast called GUcast that I know many of you listen to. And our friends here at Bayer in China are helping to disseminate GUcast to many of you here in the audience. And we had a very good discussion with the EAU Guideline Committee, Dr. Tilke, who's been here at this meeting, and Dr. Giannarini and Dr. Mazzoni from San Raffaele. So I encourage you to listen to that discussion. But I know many of you will say, hold on, Declan, wasn't there a recent randomized trial from Memorial Sloan Kettering, just published in European Urology, that seems to say the opposite, that seems to say there is a big benefit from doing pelvic lymph node dissection. So this is one of the most interesting papers published in prostate cancer this year, in my view, just a few weeks ago. This is a prospective randomized trial of standard lymph node dissection, which means external iliac only, versus extended lymph node dissection. A big trial of almost 1,500 patients. The primary endpoint was biochemical recurrence. So if you do an extended node dissection, will that improve biochemical recurrence rates? But there are some problems. So they took out 12 nodes in the standard arm and 14 nodes in the extended arm. And the lymph node involvement rate was the same in both arms. So this primary endpoint is negative. There is no benefit in terms of biochemical recurrence from taking extra lymph nodes. However, and this is where it gets interesting and a little bit contentious, they also performed a retrospective analysis to look at overall and distant metastases. This was not part of the initial statistical plan. This was not pre-planned, and very importantly, they hadn't determined when clinicians should do a scan and what type of scan to do. And there was no quality control on those scans. So you have a mixture of patients getting different types of scans done at different endpoints. But nonetheless, the team from Memorial confidently tweeted out, this is the first single-center randomized trial to show a treatment effect. Extended lymph node dissection is superior, despite the primary endpoint being negative. And Dr. Tujer says, extended lymph nodes reduces metastases, but does it really? This is the question. This is the Kaplan-Meier curve. And the conclusion is very strong in European urology. The opposite of what I just said to you. Patients should undergo extended pelvic lymph node dissection if they're having a radical prostatectomy for whatever type of cancer. So this is a concerning conclusion, and there will be a very strong editorial published by the EAU Guidelines Committee in the next couple of weeks. And we've been invited to do a second editorial about this. And indeed, we've done a further podcast just recently with Dr. Tujer talking exactly about this. And in this podcast, we raise all our concerns about the methodology, the statistical techniques, and the fact it just doesn't seem to make sense. And we've published some of this on these short TikToks that we like to make from this. We can listen to Dr. Tujer actually saying
the fact that a pelvic lymph node dissection is a good staging procedure. A good lymph node dissection, by that I mean an extended pelvic lymph node dissection, has been shown statistically to reduce distant metastases and any metastases.
Okay, so they're very confident about it.
The difference between the arms is 12 lymph nodes in the standard arm and 14 in the other arm. So is taking out 2 extra lymph nodes, and I think the operative time was 2 minutes. You know, it would be a very health economic effective thing to do if it reduces metastases. Spend 2 minutes and pluck out 2 more lymph nodes. How can that lead to the reduction? And then you keep looking, you keep doing more testing, and that's multi-testing. But data dredging or p-hacking is when you do so much testing and you're going away from your primary endpoint until you get to a p-value that's significant, which is what's got this trial all the attention.
Kind of a way of torturing the data.
Plus, in this instance, it's metastases you're measuring, which are measured on an imaging modality that's not pre-specified, and different types of imaging are being used at different time points. And the absolute difference is so small. You're talking about a few.
So we therefore have some concerns about this, and indeed we had a further podcast, especially for our China edition of GUcast, supported by Yao Zhu, who's our China editor for for GUcast in China, and Bayer reproduced this podcast with Chinese translation as well. So please talk to them. They're here today, and they're gold partners of ours. And again, we talked about this topic. So what do I think about this? Well, look, I still think that the role of PSMA PET is very important, but it's not the only thing. Even if you don't do a PSMA PET, the EAU guidelines have significantly reduced the emphasis, and I don't believe the Memorial trial is going to make any difference to next year's EAU guidelines. Briefly then, what about patients who are node positive? We can see it on a scan. And previously, the EAU guidelines said we could offer surgery to very selected patients with N1 cancer, but we have to be realistic and say they're probably going to need additional treatments. What do they say this year? Well, now it's not suggested. They only suggest offering surgery to N0 patients based on conventional imaging. So therefore, the role of surgery for node-positive patients has been significantly de-escalated. But what about patients who have N1 disease only seen on molecular imaging, MI N1 disease, which is very, very common in this era? That's where I'll briefly mention this interesting experience of using PSMA radio-guided surgery. So you inject a ligand the day before, and this has been pioneered by our colleagues and friends in Germany, led by Tobias Maurer from Munich originally, and now at the Martini Clinic. And this was based on open surgery initially, where we would use a detector to find these lymph nodes in the abdomen, and then take out the lymph nodes and find them as you see here. And this has promise and is now done with a robotic probe as well, but I think that this should still be considered experimental. So in conclusion, routine extended pelvic lymph node dissection for high risk is no longer recommended, and certainly not for intermediate risk patients. The nomograms seem to have disappeared from the EAU guidelines, and I don't believe that this Memorial Sloan Kettering trial will make any difference to the EAU guideline recommendation next year. So therefore, Professor Ye asked me to say, is it dead? I think pelvic lymph node dissection, yes, is almost dead. Thank you very much.
Thank you. Our two speakers made two very good presentations. They talked in very in-depth and comprehensive way. They talked about the kidney, prostate cancer, and epithelial cancer. Professor Ye made a short but very enriched talk. He talked about technology innovation, technology development, and multi-center drugs, and standards, and clinical multi-center. His talk was very systematic. Second, Professor Murphy talked about prostate cancer, and especially PLND. He talked about a typical case in China. We are also discussing PLND. Is it necessary? For what kind of patients should we do the dissection? We are also discussing this. I think this presentation is very important to China in terms of PLND. It gives us a lot of inspirations. Once again, thanks to the two professors.
Next, I will invite to the stage Professor Shi Benkang, Professor Zhou Qing, Professor Zhu Shaoxing, Professor Hu Hongmei, Professor Gou Xing to moderate the next session.
We're
now going to the second round of academic speeches. First, I will invite to the stage Mr. Steve Freeland. He will be talking about INBOG and something related to BCR. Let's welcome.
Thank you very much. It's for the organizers, Professor Ye, another great meeting. As always, similar to Declan, it's been a while since I've been here, so I've missed you. I've missed the interactions and the connections, and excited to be here again. And we have some new data to present from the EMBARK trial. These are my disclosures. So we know, and we heard from Dr. Murphy, whether we should be doing lymph node dissections for surgery. And the reason we would think about that is because surgery is not always curative. Sometimes patients fail surgery, sometimes they fail radiation. And for years, we've wondered what to do with those patients. We know once they have metastatic disease, we treat with hormonal therapy. And if we add an androgen receptor pathway inhibitor, such as enzalutamide, though there are others, we can improve survival. So the question is, can we apply that concept, intensified hormonal therapy, to earlier stage at biochemical recurrence? And that was the question that we sought to ask and answer in the EMBARK trial. So EMBARK was a global phase 3 trial of patients with high-risk biochemical recurrence. High risk defined as a PSA doubling time less than 9 months. They had to have a high enough PSA to go onto the study. They could not be candidates for salvage local treatment. If they were candidates for salvage radiation, they should get that. This is when we're ready for systemic treatment. This answers the question of how to do that. They also had to have conventional imaging negative prostate cancer. PSMA was not around when the study started, so conventional imaging negative. Randomized to enzalutamide plus ADT, ADT alone, or actually for the first time ever in a phase 3 trial, enzalutamide alone. If they got a good response, treatment was stopped at 9 months and then restarted when the PSA would start to rise, and the primary outcome was metastasis or death. Really bad things that we want to prevent our patients from having. This is the baseline characteristics: median age of around 70, median PSA doubling time of about 5 months, and median PSA of about 5. And the question is, does it work? And the answer is absolutely. Relative to ADT alone, you see that the enzalutamide plus ADT, the Kaplan-Meier curve is up higher. Those curves start to separate as early as 12 months and keep getting further and further and further apart, such that adding enzalutamide reduced the risk of metastasis by 58% by just adding enzalutamide. And this translated into an early suggestion of 41% reduced risk of death. This is early. We're still following the patients, and we'll have more to report either late next year or early 2026. So the next question is, do you even need ADT? What about enzalutamide alone? And we see here that that also worked and reduced the risk of metastasis or death by 37%, with again curves that continue to separate further and further over time. And a suggestion, again, still early, of a 22% reduction in the risk of death from any cause, really showing dramatically that we can delay progression, keep our patients alive longer. One of the unique aspects about EMBARK was if patients got a good PSA response, we stopped treatment. So the question is, how often does that happen with these therapies? And if we look on the left, if you get enzalutamide, you are much more likely to get that treatment suspension. Over 85% for monotherapy, over 90% for combination, relative to only 2/3 of patients with ADT alone. Meaning 1/3 of patients with ADT alone did not get a good enough response and now have to be castrated for life because their PSA didn't go down low enough. And then how long does that treatment suspension last? It lasts longer if you're on enzalutamide combination, over 20 months, 16 months with ADT alone, and with enzalutamide monotherapy, Remember, these patients are not castrated. Their testosterone actually goes up. And so whenever you stop the enzalutamide, all that testosterone floating around is going to make that PSA go up quicker. So I've shown you delayed progression, greater chance of being off treatment. But what is the impact to the patient on their quality of life? Because these are asymptomatic biochemical recurrent patients. Are we making them sick to get these benefits, or are these drugs well tolerated? And so we looked at that. And this is a complicated slide, but I can walk you through it. Every 12 weeks, we asked people to fill out surveys, tell us how they're doing. And sometimes their answers said they're not doing as well, but we don't know why. Did they have a cold? Did they trip and hurt their ankle? Did they get into a fight with their wife, husband? We don't know what the reason is why these patients are having decreased quality of life. So we would ask them 12 weeks later, how are you doing? And sometimes they would be back to normal. Sometimes they were still low. So we looked at the time to first deterioration and time to confirmed deterioration. We looked at pain, because they're cancer patients. You always think about pain. And we looked at overall quality of life. And what we found is whether we looked at combination, monotherapy, first decline, confirmed decline, pain, global quality of life, no matter how we looked at it, all of these cross one, meaning no statistically significant differences, meaning we are preserving quality of life. Remember, they're asymptomatic, so we're not making it better, but we're not making it worse, which is very important. We weren't necessarily happy with this. We said there's got to be some differences. Let's look at the data deeper. And so we looked at it, multiple different measures of quality of life. And I put in boxes the ones that are statistically significant. And you see there's very few boxes. So again, quality of life is preserved. You do see a little bit more hormonal treatment-related symptoms with combination. Makes sense. It's better ADT. Better ADT should have more ADT-like side effects. Makes sense. But importantly, on the bottom there in monotherapy, we see better preserved sexual activity. And for the 60% of patients who at baseline said they were interested in sex, this is very important for some of those patients, that we can get anti-cancer activity and preserve sexual activity now with enzalutamide alone. It was a median follow-up of 5 years, and we know ADT has side effects. So you see most patients had some sort of adverse event. And if we look at the serious adverse events, even with ADT alone, it was over 30%. And adding enzalutamide increases those numbers slightly. Quality of life is preserved, but there's still side effects. And if we look at specific side effects, if we look in the middle at ADT alone, and then we look at the ADT plus enzalutamide on the right, or on the left, sorry, left, right, what we see is that all, for the most part, all the side effects are a little bit more. Makes sense. Again, enzalutamide plus ADT is just better ADT, so it's going to have more side effects. So the monotherapy is interesting. Remember, patients have normal testosterone. They have high testosterone. That testosterone will get converted to estrogen, and the estrogen will do 3 things. First, it will go to the brain and tell the brain you have plenty of hormones. You don't need to have hot flashes to tell me there's a problem. You have hormones. So the rate of hot flashes is relatively low. Not zero, but low. Second, that estrogen will go to the breasts and cause the breast to start to grow. 45% rates of enlarged breast, 15% of nipple pain. I think if we radiate the breasts beforehand, we can prevent some of these. Tamoxifen, aromatase inhibitors, surgery if we need, there are treatments. And then the next one is all that estrogen is going to go to the bones and make the bones stronger. So if we look at the rates of fracture, what we see is that it's 18% on the ADT plus Enza, 14% with ADT alone, and only 11% with monotherapy. We see the least amount of fractures with enzalutamide alone. So in summary, for patients with high risk biochemical occurrence, not all patients, high risk biochemical occurrence, who have now failed local therapies and are ready for systemic treatment, whenever that is, we have options. ADT alone is no longer good enough because enzalutamide, either with or without ADT, improves cancer control, hit many of our secondary outcomes, no new safety signals, and very important for this asymptomatic patients, we preserve quality of life and really is the new standard of care for these patients. We published the primary results in New England Journal of Medicine, and then the quality of life was a New England Journal of Medicine evidence. And there was a global study, 244 sites, 17 countries and regions, really all over the world. Thank you for your attention.
Thank you very much, Professor Stephen Freeland. It's a very famous EMBARK trial, and he's explained very well all these statistics and their interpretations. So for high risk biomarkers recurrence patients with ADT plus Enza and plus monotherapy versus monotherapy. But now I see that the monotherapy has a good effects, and in terms of quality of life, monotherapy has many advantages. For example, preservation of sex life, reduction in fractions of bones. So for these patients, monotherapies of enzalutamide have a good perspectives. Maybe Chinese doctors they rarely use monotherapies of enzalutamide, but Professor Freeland have given us good inspirations and explorations in future treatment. Thank you, Mr. Freeland.
Next, our speaker is Professor Axel. His topic today is application of PARP in mCRPC. Now let's give him a warm round of applause.
It's my pleasure to be speaking here, and it's a great honor to be first time in my life in China. I prepared a video. It would be great if I could show it, if it's possible to pull it up. Otherwise, I can just proceed. It's just a great honor, Professor Ji, to get invited here and to speak on a pretty complicated topic. It's on PARP inhibition. And I like Professor Friedland's topic introduction with enzalutamide, because I think enzalutamide and ARPs are a great combination partner with PARP. So here are my conflicts of interest, and fewer than 50% of patients with mCRPC unfortunately receive life-prolonging therapy beyond first-line therapy, where in biochemical recurrence, we don't have deadly disease. Sure, we have to do a lot for our patients, but fortunately, it's a long time until something happens like metastatic disease. Here in MCRPC, we just have a couple to 3 years of treatment, those men. So only a few patients receive second, third-line treatment. And hence, we have a lot of options to treat metastatic and advanced prostate cancer. And I have to update this slide every year because it's really a lot of what is added to the armamentarium and how we treat advanced and metastatic prostate cancer. So I think they will update me now with my slides. 3 seconds. It's a surprise, just a second. Perfect.
Dear colleagues, I'm very honored to come to China for the first time and talk to you. I look forward to the academic discussion. But as I don't speak Chinese, I'll switch to English.
So this was my medical avatar. My Mandarin is not that good, so I will switch over to English again. But a great honor, and I try to prepare home at my office. So a lot of options we have now in metastatic prostate cancer, and now I have my real slide deck. So selection of treating MCRPC patient is not so easy. So even though we have a lot of treatment options, we have to decide very wisely what's the best treatment for the patients we see in our clinic, in our office. And here, for example, short response to MHSPC treatment, high tumor burden, high risk, high volume, rapid pace of progression. Those are aspects where you might consider chemotherapy, triplet chemotherapy, PARP inhibition, or if you have a clinical trial. I was impressed by the organizers' clinical development program, and I also saw at ASCO and ESMO meetings, at EAU meetings, your activity. I'm very honored to be here to see it live in China. So the life-prolonging agents we have, I would like to focus on the PARP combination and PARP monotherapy. And the preclinical rationale for combining PARP inhibition and ARP is not so easy to understand, and we tend to torture our residents. So what are the 4 pillars? And you see, these are the 4 pillars that led to the clinical trials that led to approval of PARP combination. So we know and we have learned that a combination with ARP and PARP really prolongs the progression-free survival and recently has shown to prolong also overall survival. So the preclinical evidence was there, and it was quite exciting. And Noel Clark from UK was the first that investigated in the study 8, first demonstration of clinical benefit of genetically unselected MCRPC patients receiving olaparib and abiraterone compared to abiraterone alone. And this showed a benefit, this phase 2 trial. And this led to the large development program phase 3 trial, the magnitude trial with niraparib, the POPEL trial with abiraterone and olaparib, and the latest publication was TALAPRO-2 trial, which led to approval of talazoparib and enzalutamide versus placebo and enzalutamide. This is the label in the recommendations from the guidelines, and the guidelines focus on the HRR mutation status. So they recommend to use this combination when you have men which have an HRR alteration. However, the label is quite different, whereas we in Europe have all-comer labels for the PROPEL and TALAPRO indication. In the US, it's BRCA mutated only or HRR mutated only. as you see here on the slide. In your country, it's also restricted to HR mutation. However, this might change, and I'm not involved in your regulatories, but we will see overall survival benefit pretty soon in a couple months for the TALAPRO-2 trial. So here, the differences, even though those trials were pretty similar and the indication was all MCRPC, we had differences with regards to the testing, with regards to what has been given before. For example, TALAPRO-2 patients were allowed to receive docetaxel and also abiraterone in MCSPC patients. Positive primary endpoints for all three trials. And as mentioned, PROPEL and TALAPRO trial was an all-comer trial. So here really we have an RPFS benefit. And you see this RPFS benefit was also translated it also worked in the all-comer population. So we have a hazard ratio of 0.76 for the PROPEL trial and 0.66 benefit, giving the combination instead of just the RP in MCRPC situation. And this is my almost favorite slide in this talk. It looks a little bit complicated, but you see there are differences in the PARP inhibitors. And where you have the PARP blocking or the ability to trap PARP on the DNA is the highest for talazoparib, followed by olaparib, then niraparib, and latest rucaparib. And this maybe translates into side effect profile and might also translate into efficacy, which we see is different in those trials. Overall survival, as of yet, not mature, but you see the curves, the separators are going towards the triplet, I would call it even triplet therapy in MCRPC. So an RP, ADT, and a PARP. And just the small box, as of October, there was a press release that talazoparib in combination with enzalutamide prolongs overall survival, and I suspect we will see the data at ASCO GU in a couple months in San Francisco. So exciting data going to be seen for TALAPRO trial. The HR deficient group, this is the secondary endpoint here. You see the overall survival curves for all three trials. As said, the magnitude trial were just for the man with the HR mutation, whereas PROPEL and TALAPRO-2 were trials with an all-comer population. This is some latest data, TALAPRO-2 objective response rate. Here you see a 62% ORR versus PROPEL data here, so very good, robust data. When looking at the adverse events, yes, surely if we deliver radiographic progression-free survival benefit, if we show that in the future also overall survival will be prolonged, this comes with a price, but I think there were safety signals that were well tolerated in experienced hands. And I think most important to mention is the anemia, which led to, regardless of the PARP inhibitor, 20 to 40% transfusion rates throughout the whole course. But as said, most of the transfusions and most of the anemias come at an early stage, the first 3 months of the treatment. And this is like the adverse events throughout the 3 trials. Effective HRR repairs can and do contribute to prostate cancer pathogenesis. And I think this slide I like a lot, the outcome of first-line treatment of patients with MCRPC. You see the graph on the right side. So BRCA men in MCRPC have an overall survival of just 18 months in average, whereas it's non-BRCA, it's more going towards 28, 30 months. So those men with the HR mutation have a bad prognosis, and definitely I would urge you in your clinics, in your private practices, to do testing and then treat and label. So because men with a BRCA alteration, they really need a PARP inhibitor and best a combination. I sometimes get the questions, even from experts, can't we just start with enzalutamide, or can't we just start with abiraterone and MCRPC? We have the label. Yes, we can, but then you're on the bottom curve, and you want to be on the top. And the top curve here from Brucker-Way study showed when you combine, in this instance, abiraterone and olaparib together at the beginning and don't sequence in those men here which are positive for germline or somatic alterations, you have the best benefit. So if you have a mutation, please combine up front and don't sequence, because you have triple of the overall survival or the RPF situation here. So this is the reason why I think it is good to conduct HRR gene mutation testing, depending on your local situation and approval and also costs. It's in some countries like Switzerland, every metastatic prostate cancer man will get tested. In Germany, it's when it comes from MHSPC to MCRPC, and because you know the family risk of cancer, you have treatment options, and also know something about the prognosis. You can do germline testing or somatic testing, which overlaps once in a while, but about 15 to 25% of men with advanced metastatic CRPC have an HRR mutation, and a lot also BRCA1, BRCA2. So the germline DNA repair mutation should be assessed regardless of the family history, because when moving back, the somatic testing can only be done in tumor tissue, whereas the germline testing can be also done in blood. And there's an overlap, but also there's the situation also where you only have a somatic alteration. So I think it is important to test and maybe even retest at a further course of the disease. So when to conduct HRR testing, it is different what the guidelines recommend. As Professor Murphy alluded to in lymph node dissection, this can change, and the same can change also for the testing, molecular testing, and also what panel is being used. So we have different ESMO, EAU, AUA, and NCCN recommendation for the testing, but in summary, all like in MCRPC stage recommend the testing. So just to be a little bit provocative for the discussion later, this is a possible new or modern MCRPC sequence. So nowadays we should not start in metastatic prostate cancer with just ADT monotherapy. And we have learned even in the era of EMBARK data that a combination is also possible. So in a lot of cases, we start with a combination or maybe even triplet therapy. So what's the next step? And I think here, definitely for the HR mutated man, a PARP combination is the gold standard nowadays. Whereas in HR non-mutated, this is a point of discussion. We have other options like docetaxel, radium-223, lutetium therapy, carboxytaxel. So it's really a lot we can offer our man in this advanced disease. Surely ADT should remain the backbone treatment of advanced prostate cancer. And please don't forget about osteoprotection. I think this is also very important to focus on the bone health of those men. So dear colleagues, friends and guests, this is my conclusion. So in summary, the HRR mutation is really important. In MCRPC, we have PARP and RP combination that led to approval also in China. And we will see overall survival data in a couple months from now for the TALAPRO trial. So very exciting times in advanced prostate cancer. So thank you very much, Qin, and thank you again for inviting me to your conference.
Thank you for your presentation.
In a very short period of time, Professor Axel talked about 3 clinical trials. He talked about the use of PARP in MCRPC. He talked about the benefit to the patients and possible the sequential treatment solution for patients. Thank you.
We have 4 commentators, 4 guests to commentate on the presentations. We will invite the experts to the stage.
First, let's invite Professor Jing Baiye. Thank you for the invitation. Today, we listened to many important speeches. Just now, the two speakers talked about Embark and Propel and the other clinical trials. We feel that in different stages in the use of drug, we can have many advantages. In the Embark research, combination is the best to survival. In terms of the overall situation, enzalutamide alone has its advantages. PARP plus RP to RAC2 patients and the patients with HRR defects can bring some effects. We feel that the two maybe we have differences in number of patients between China and Europe and the US in this area. So maybe the data may be small. And compared with Propel, the other trial seems better. We look forward to more evidence. Thank you. Thank you. Thank you to the four speakers. One from China, three international speakers, very enriched content. So Professor Ye gave a very macro talk. He talked about his achievements, and I feel a bit ashamed in comparison. Why? Because I think I haven't done enough. Yeah. I just pressed on the screen. I think Mr. Ye has a lot of high-quality papers, so I feel very humbled. Professor Murphy, I'm very interested in what he talked about. How do we clean lymph nodes? Well, now we have ICG, nano. A short while ago, we used ICG. We use the robot, use the SI. We can see the number is decreasing. The picture is very good, but it's a pity that no positive. So I said that you have done a lot of shows for dissections. How many are positives? Don't not even mention complications. So I think Professor Murphy, you should really promote this message in China. Should we revise the guideline? We shouldn't be obsessed with the guideline. We should be patients first. We need to provide customized and precision treatment. And Professor Stephen is also made very interesting talks. We talked about castration. We put castration first, and then we talk about other drugs. Today, he talked about enzalutamide. It's very good, especially for some complications. So we really need to think about this. So innovation is actually right in front of us. We just don't dare to do that. People say castration is foremost, but no. NHT, enzalutamide. Also, we have other drugs. Can we use them alone? I think, Stephen, you have a lot of innovative ideas. Is that suitable for China? It's hard to say, but at least he gave us some new ideas. Professor Axel also gave very interesting talks. PARP inhibitor. How should we use that? We don't use it a lot. First, it's not used a lot because in second line, it's used when many people cannot do well. Now we have gene tests, but the tests are not consistent in many different institutions. So for us, in treating MCRPC, we really need to come up with Chinese data to guide us in our future work. We have many types of PARP. In China, we use olopardin or olopardin 2. Okay. I think that's my view. Thank you. Thank you for your invitation. I'm very glad to come to this very high-level meeting. Very good, high-quality presentations. I really feel very strongly about the presentations. Biomarker recurrence is a very common issue. So how do you evaluate it? How do you deal with it? We have combination therapies. In China, we don't have such a guideline. If you use a single medicine, I think we've learned a lot from today's presentations. Now we are in a new era. We are not using blockers one generation after another. Maybe we have many different choices. So when should we use the drugs? Or under what conditions do we use the drugs for the best effect? I think today we get a lot of inspirations. Just now, our professor talked about using one drug. At first, people said no to this, but in the ANT era, should we refuse this single drug approach? We should think about that. If we can use, PFS, OFS can be very good. Maybe we also need to consider side effects. For example, there are a lot of complications. For example, poor sleep, poor cognition. If you have new drugs, they can not enter the blood and the mental barrier. Then there are also other effects. Also, we need to consider the hormone levels. We need to do a lot of clinical research. Many new drug combinations can have an effect on the hormone levels. So a lot of very inspirational ideas. PARP inhibitors for HRR mutation and BRCA patients. That's a very good treatment. CRPC is something that makes people desperate. The two professors mentioned that in China, gene testing is not very popular. I heard that maybe it's the same in Europe. It's especially like this in China. So not many hospitals can do gene testing. What about the quality? Despite many companies that can do this. What about the positive ratio? So generally speaking, for advanced cancer, as we have more and more new drugs to choose from, we can have new combinations, new application scenarios. So I think the control of the cancer will be better and better. Thank you. Thank you for your great comments. Professor Ye, on behalf of the host, demonstrated what their team has achieved. I think that's really very refreshing. I think his institution is really a leader. As second, about PLND, I don't really want to elaborate on that. I think it seems that the era for PLND has died. I think it comes from the EAU. I think it's the direction of the EAU guideline. And then I think we also talked about embark, especially in high-risk biochemical recurrence. Is there radiotherapy? We talk about 3 drugs. Maybe in the future, the single medicine may be the trend. We need to protect the testosterone and the bones of older males, and also they can be very good in terms of side effects. Also, we cover the PARP inhibitors and the 3 trials: Magnitude, Propel, and Talazoparib. These clinical trials show that without HRR mutations, then the result is very good. The overall survival rate is very good. But if you have BRCA, then it's only 1/3 or half survival period. So early adoption by the patients will improve the overall survival. So with greater adoption in China, now the adoption is not very high. With greater adoption in the future, we can have a more in-depth discussion of this. That's the end of this session. Now let's invite the next speaker. And some other.
Invite to the stage the moderators for the next round, Professor Zheng Junhua, Professor Bian Jiahui, Professor Qian Weijing to the stage. So the first session is themed on integration and innovation. The second one is on thoughts and transformation. We have arranged for 2 international experts to give presentations, and Professor Zhang Xiaoping, Professor Hu Zhiquan, Professor Fu Qiang, Professor Liu Nan will be giving comments and engaged in discussions after these 2 presentations. First, I will give the floor to Professor Karim Firazal. He will be talking about radioligand theranostics in prostate cancer. Welcome.
Good morning, and thank you very much, dear chairs, dear colleagues, for this really kind invitation. So I will speak about PSMA targeting and radioligand therapy in the coming talk, which I think is transformative for men with advanced prostate cancer. Those are my disclosures with participations to advisory boards and talks for pharma companies. And I think you're already all familiar with PSMA, which is a transmembrane protein. And this is highly expressed in most men with advanced prostate cancer. And the good news is that it's rarely expressed by normal cells, with one exception, which is that of the salivary glands. Clearly, PSMA expression is actually linked to aggressivity and to advanced disease. So the more the cancer is, the more you will see the expression. Targeting PSMA can be used for imaging. We are all using PSMA PET, but it can also be used for treatment, using, for example, radioligand therapy, and now also some others. So the concept is as follows. You will inject a ligand in the vein of the patient. The ligand will bind to the protein on the cell surface, and because the ligand is bound to a radioisotope, the radioisotope will hopefully kill the cancer cell. So this was invented actually more than a decade ago by all our German colleagues. We have to thank them for that. then developed in a phase 2 trial and then a randomized phase 2 trial by the Australian group. And then we could see the very first phase 3 trial, Vision, which actually read out approximately 3 years ago. So this is the design of Vision. These patients had castration-resistant disease, metastatic disease, obviously. Their PSMA expression was demonstrated based on PSMA PET, and they had exhausted basically everything, androgen receptor pathway inhibitors, taxane, so that they were randomized to receive standard of care, what was remaining, versus the same, plus lutetium PSMA for up to 6 cycles of treatment once every 6 weeks. Patients were screened again using a PSMA PET and a CT scan to make sure that non-PSMA expressing cancer were not allowed in the trial. As I said before, these patients really had very advanced disease. Most of them had exhausted not only one AR pathway inhibitor, but actually 2, and many of them actually had exhausted not only docetaxel, but also cabazitaxel chemotherapy. The primary endpoint of the trial, or one of the 2 co-primary endpoints, was clearly improved. As you can see here, radiographic progression-free survival was postponed with 60% reduction in the risk of progression or death, favoring lutetium PSMA. But most importantly, of course, overall survival was significantly improved with a 40% reduction in the risk of death, which is not something we're seeing very often in oncology, including prostate cancer. You might say, oh, this is all nice, but can my patients tolerate this treatment? And we all see patients in the elderly, of course, so we want to make sure safety is being met. And indeed, fatigue is seen in excess, but this is not a marked fatigue, as you can see, mostly grade 1. Bone marrow suppression is something we should pay attention to, especially in patients with multiple bone metastases. So clearly these patients benefit from treatment, death is postponed, progression is postponed, but you also need to be prepared to transfuse some of your patients if they have multiple bone metastases. And I'll come back to that in a second. Dry mouth is a side effect of treatment, but it's really mostly mild dry mouth and very transient. Typically in my patients, 1 or 2 days, and then it's out. Nausea and vomiting is also something that is related to treatment. It can be very efficiently prevented. I'm using a citron slash a corticosteroid as a prevention strategy, and clearly it works. So that's something that is important to know if you are about to start treating patients. Not only death was postponed and progression, but also deterioration in quality of life was clearly postponed in the trial. As you can see here, medians approximately 10 months versus only 2 months in the control arm, and pain intensity was, deterioration was also dramatically improved, 14 months versus 3 months in the control arm. So clearly you have a clinical impact to your patients when using this treatment. Time to first symptomatic skeletal events was also significantly improved. And again, quite impressive. We're basically doubling it, approximately 7 months versus approximately 12 months for lutetium PSMA. And of course, as you all know, this includes fractures, spinal cord compression, and major pain requiring radiation therapy. Having said that, this is really a first. There are many unanswered questions regarding the use of radioligand therapy and more generally, PSMA targeting in this disease. For example, in Vision, we used a fixed dose of lutetium PSMA, but we don't really know whether this is the best thing to do for the patients. And actually, we may individualize treatment in the future. We need data regarding this question. Also, I told you that in Vision, we were, I think, very pragmatic at selecting patients using a PSMA PET and a CT scan correlation to get rid of patients with PSMA negative cancers, but also you might argue whether this is the best way to select patients, and there are pros and cons to be more or less stringent. Very important clinical question is whether we should discontinue PSMA lutetium treatment in patients with fantastic responses, those with a complete response on treatment. If you carry on with treatment, the lutetium PSMA might actually go to normal cells, not anymore to cancer cells. So this is also something we should address, and the Australian group has already started to do that. I'll come back to that in a second. Audio use, as we often do in oncology, I'll give you the first data. Combination is also something we are looking at. Also, as I said, some patients are responding tremendously. So the question is whether we should retreat these patients after 12 months or 2 years when they start reprogressing. And this is also an open question. Should we keep using beta emitters with lutetium, or should we eventually move to alpha emitters such as actinium, for example, and also non-radioligand treatments targeting PSMA? I'll show you a few data. Most importantly, we need to understand primary and acquired resistant mechanism, and there might be also some other cancers that may benefit from PSMA targeting, such as, for example, kidney cancer. Let me give you a few data that just emerged in the last 2 years or so. So first, expression is clearly correlated with efficacy, crystal clear. Having said that, even patients with a low expression still benefit from PSMA targeting versus nothing. So it's not a good reason not to treat. Early use of treatment, this is really an intense subject for study. PSMA addition in patients with castration-sensitive disease has completed its accrual. PSMA4 and SPLASH just released their first data. I will show that to you in a second, and PROSTAC should do this soon. So PSMA4, this is the second randomized phase 3 trial that we have with lutetium PSMA, this time in patients with castration-resistant disease pre-chemotherapy. They had exhausted one AR pathway inhibitor, but no chemotherapy, and lutetium PSMA was compared versus RP change. Again, this time lutetium PSMA was given once every 6 weeks for up to 6 cycles, and I think this is important. I'll come back to that. The trial is clearly positive. RPFS is postponed, 60% reduction in the risk of progression or death, ranging from 6 months in the control arm to more than a year in the experimental arm. Crystal clear, we are improving time to progression or death. But it's also preventing the worsening in quality of life. This was shown whatever the way we assess the data, quality of life deterioration is postponed, very clear. Same for if you're looking at a time to pain deterioration, we are improving that. Again, whatever the way we are capturing the information, pain is just postponed. But the toxicity in this second trial was actually quite excellent. And actually, this is a very good reason probably to treat early in the course of a disease. It actually makes sense. If you are targeting patients with just 1 or 2 or 3 bone metastases or lymph node disease, the radiation therapy will not go to the bone marrow, and hence you will see less toxicity as compared to if you're treating patients with tremendous bone disease. And actually you can see here anemia, fatigue was seen in a very comparable fashion in the 2 arms. As I said before, there might be some other means of targeting PSMA. Actinium, for example, an alpha emitter, is emerging as a new treatment with some efficacy post-lutetium PSMA. So if confirmed, of course, this would be a very important findings. There are other means of targeting PSMA, radioisotopes, but also ADCs, CAR T cells, bispecific, And all this is really emerging very rapidly now. We should see data in the coming years. And we will see eventually whether we should combine or sequence all these treatments or maybe not. As I said before, PSMA is a very important target, but there are other important targets emerging for potential treatment with radioisotope. STEAP1, which we saw about a year ago, but also kallikrein-2 was demonstrated to be an important target for the very first time this year at ASCO, and this was shown with actinium-based treatment. You can see here on this waterfall plot that most of these patients with advanced disease who had exhausted basically everything actually derived benefit from treatment using kallikrein-2 targeted agents. So, in conclusion, PSMA targeting clearly works. Radioligand therapy is probably here to stay. We now have level 1 evidence that we are postponing progression, postponing death, postponing deterioration in quality of life, postponing deterioration in pain. So all what we want to see in all our patients, with, generally speaking, a quite nice safety profile for most patients, as opposed to many other treatments we're using in oncology, including for prostate cancer. If you're using the same treatment in less advanced disease, your patients will still benefit, and perhaps benefit even better, with less toxicity, because the radiation therapy will not be associated with bone marrow suppression. And again, this is really just the beginning. If you think about it, we just saw the very first phase 3 evidence 3 years ago. This is just emerging scientifically. There are many open questions and, of course, opportunity that remains. We need to address them prospectively and collectively. Having said that, patients with PSMA targeting or treated with PSMA targeting still die at the moment when treated in the late stages. So we need to understand how cancer cells are able to circumvent resistant to this treatment. Is this based on remaining PSMA expression? Is this based on PSMA negative progression? We need to tease this out to invent new strategies and make sure most patients benefit. Early use seems to be associated with even more meaningful benefit, and more data is soon to come about the use in earlier stages. With this, I thank you very much for your kind attention, and I thank you again for this very kind invitation to Shanghai. Thank you very much.
Thank you very much, Professor Fazazi, for the radioligand theranostics in prostate cancer, and he used the Lu-177 plasma. In some areas in China, there's already application of a Lu-1777, and these therapy has opened up new perspectives for treatment, especially for advanced stage prostate patients. There's a certain efficacy. This can reduce the pain, can also enhance survival rates. He also highlighted that in earlier stages, the efficacy might be even better. So in China, we are also exploring this path. The radioligand in the treatment of prostate cancer can be seen as one important approach of treatment. If it is combined with other treatment tools, it can strengthen the treatment of patients and enhance overall survival rate. This is one very inspirational piece of news for us. Thank you again.
Next, let's invite Professor Andrea Necki. He will talk about model management of patients with MIBC from standard treatments to clinical trials. Welcome.
Professor Ye and dear colleagues, it's a pleasure to be here for me for the second time. first time after COVID period. So thank you again and good morning, everyone. So let's shift our topic on bladder cancer. I will try to navigate with you on the next 15 minutes on the management and of developments that occurred in the management of muscle-invasive disease as regards perioperative therapies, the neoadjuvant and adjuvant therapies. I have a conflict. So why we are dealing with muscle-invasive bladder cancer? 25% of the patients jump into this clinical stage from previous non-muscle invasive stage or because of the diagnosis of de novo muscle invasive disease. We are dealing with a deadly disease. So 50% of the patients actually die from the disease, even when achieving the standard of care therapy, radical cystectomy or chemoradiation. So there is a huge unmet medical need. And there are multiple opportunities in looking at perioperative therapies, you know, neoadjuvant therapies in particular, because of many reasons, the deadly diseases that I said, the time frame between TURBT, the diagnosis, and radical treatment, in which we can deliver or we can test the newer therapies, the uncertainties that are still related to the adjuvant postoperative therapies with regards to chemotherapy, and also with regards to immune therapy, in particular for long-term overall survival data we will see in the final slides. We are lucky because from China to Europe to United States, we have a pretty much consistent clinical model in which we can test the newer therapies, you know, T2, T4, N0 or N1, M0, muscle-invasive disease with pure predominant urothelial carcinoma histology is the clinical model. It is pretty much shared in the community to test newer therapies or to use the standard of care therapies in the neoadjuvant setting. So this is a very good point from the clinical research perspective. A very complicated slide, just to show you what has been done in terms of trials, testing newer therapies, in particular with a focus on immune therapy alone, or immune combination therapies. Please focus the attention on the role that is related to the pathological complete response. Overall, the message that we got from these studies is that we do have clearly a signal of activity. Even when using short course, single agent therapies, 2 or 3 courses of neoadjuvant immune therapy. Are these data sufficiently robust or strong enough to envision a future, save the bladder, to overcome the limitation of radical cystectomy? Maybe not, we will discuss a little bit more later. We are dealing with the immune checkpoint inhibitors, assuming that atezo is equal to pembro, is equal to nivolumab, but maybe not the same. Please look at these slides. It's one of the many translational work that have been done in the neoadjuvant setting. In particular, look here, the combination of the genomic data and the biomarker data from Abacus, atezolizumab neoadjuvantly, and Puro-1 pembro neoadjuvantly, and focus, for example, on the immune basal subtype. Here you see the pathological downstaging rate with pembro as compared to atezo, completely different. So the effect of the drug in molecular subtypes is completely different. So maybe there is an effect, a differential activity, a differential effect across the immune checkpoint inhibition at least in this clinical model. So it is very important to take this into consideration when looking at the clinical outcomes. What regards to the combination of immune therapy and standard chemotherapy? Chemotherapy cisplatin-based chemotherapy. Again, focusing on the effects on pathological complete response. Here we have less intriguing result to me, because if you remember the previous numbers, we are almost on the same range, 40, 30%, in between 30 and 40%. Doesn't seem to be a huge step forward, you know, when combining chemo and immunotherapy as regards the intermediate endpoint of pathological complete response. But there are trials, phase 3 trials that are running, and a few of them already have presented results, testing the perioperative stage, so neoadjuvant step, surgical step, and adjuvant postoperative step. The trials are shown here. The Niagara study is the first study to present results and to present positive results with regards to the primary endpoint of event-free survival, and also overall survival was positive, as we will see. This was the design of the Niagara study, very, very simple design, phase 3 study comparing Durva immune therapy and combined to gemcitabine and cisplatin versus standard of care GemCis, followed by radical cystectomy. In the experimental arm, there was a tail of maintenance or adjuvant immune therapy with durvalumab for 1 year, as compared to observation as a standard of care. Event-free survival and PAT-CR were the two co-primary endpoints for the study. It's clear that the study is pretty well shaped to set a new potential therapeutic option for the patient because of the survival advantage. Event-free survival was met, overall survival was met. Let's focus a little bit on the attention on the other co-primary endpoint, which is interesting to me in order to see what we will discuss a bit later. It is about the pathological complete response. These are the two analyses, the primary analysis on the left-hand side and the reanalysis in more cases on the right-hand side, showing that there is a trend for improvement in the pathological CR. But the rate is not outstanding, you know. Either with the use of Durva, GemCis, or GemCis alone, we are navigating across 25%, 30%, 33% PAT-CR. And if you look at the most modern data from PAT-CR rate, from modern studies testing or using standard of care chemotherapy and dose dense and VAC of GemCis, these numbers seem to be pretty much higher with regards to this intermediate endpoint. So this is pretty much concerning when dealing with the issue of potentially avoiding radical cystectomy, so the removal of the surgical part of these perioperative studies, you know. Another point that is missing in Niagara, and it is being tested in patients who are ineligible to cisplatin-based chemotherapy or who refuse cisplatin-based chemotherapy, is the role of immune therapy alone or immune therapy combined with ADC, like studies with the ADC EV-Pembro combination neoadjuvantly. And there are trials testing these options for the same patients. This study readout is still pending, so we will see if there will be an additional step forward beyond chemotherapy. And another pretty exciting step is about the possibility of combining an intravesical therapy with systemic immune therapy in patients with muscle-invasive disease. You know, intravesical therapy is pretty much used in the BCG unresponsive disease, so non-muscle-invasive disease. Sunrise-4 was one of the first studies testing or introducing intravesical therapy with TAR-200, which is a small silicon tube that is providing a continuous, sustained release of gemcitabine intravesically. It is removed, recharged, and re-put in the bladder every 3 weeks, every 21 days, with a simple outpatient procedure. TAR-200 was combined to cetrelimab, an anti-PD-1 antibody, or cetrelimab monotherapy was tested in the Sunrise-4 study. 4 cycles before radical cystectomy. Here the primary endpoint was the PAT-CR. And these are the PAT-CR rate or pathological major response rate, so downstaging to non-muscle invasive disease across the various populations. The all-comers, clinical T2, T4, with a 60% downstaging to non-muscle invasive disease, and in various subgroups. Let's in particular focus on the clinical stage. In clinical T2 stage patient, the PAT-CR rates rise to almost 50%, with a PAT downstaging rate to almost 70%. So, other intriguing data to combine with the data from larger studies to Niagara study when looking at the next step forward in these patients. Neoadjuvant therapies means also educational opportunities, you know, for young fellows. Chiara Marcinelli was the first name of one of the last papers that we published from our studies, combining Nivo and another way of using chemotherapy taxane-based chemotherapy in cisplatin-ineligible population. There are multiple reasons why taxanes may be a better companions as compared to platinum chemotherapy with immune checkpoint inhibitors. And intriguing results have been presented. So I suggest you also, when looking at your fellow, to provide them with an opportunity for investing in their career on the neoadjuvant studies or perioperative studies that may provide also the opportunity to invest on biomarker research, invest on and build their career on geocancers. And just to mention that the only targeted therapy studies, it is a trial in progress study, no result has been released to date. The only targeted therapy studies with erdafitinib alone or with immune therapy in FGF receptor altered muscle invasive tumors. Primary endpoint is pathological complete response. This is an academic study running in France, Spain, Italy. So a huge effort that is ongoing in the European side in this same clinical setting. So in my viewpoint for neoadjuvant preoperative therapies is something like this. So clearly, if you identify the success area, you know, for the 2-year overall survival rate, which should be higher than 80% in this patient population. Niagara study is pretty well positioned, but we should also consider the standard of care options of dose-dense and VAC chemotherapy that is here playing a role as compared to GEM-CIS chemotherapy. But when it comes to the issue of pathological complete response, we are still a bit low the bar of success that I assume is about 50% or higher when dreaming or when thinking about the opportunity to save the bladder to the patient with any newer neoadjuvant therapies in this patient, and saving the bladder and saving radiotherapy on the bladder also for the patient. This is the new wave for contemporary research in this field. We do have data from ADC neoadjuvantly as monotherapies in enfortumab, sachi, dizitamab vedotin. The point that we like to highlight here is that even either with the enfortumab or sachi, we provided safety issues because these studies reported grade 5 events in a few patients, meaning that testing newer therapies neoadjuvantly also means having a special focus on safety. Losing one single patient in this clinical setting is critical, is problematic. So having reporting toxicity data in this clinical setting is problematic. So we will eagerly await the data from EV-Pembro, also with regards to safety issues in this patient population. What about Anna? Anna is a typical today patient. We are not dealing with clinical trials, you know. Today, everyday patient are similar to her, 44-year-old female presenting with a clinical T3 tumor, receiving GEM-CIS chemotherapy, so nothing within trials, you know. Achieving a clinical complete response, no evidence of disease, of MRI, CT scan, cystoscopy, and at this point in time, she was originally in favor of radical cystectomy, but at this point in time, based on the depth response, on the deep response to chemotherapy, she refuses chemotherapy and sit down in front of the doctor and say, okay, doctor, you have done a good job. Why have to go to the operating room at this point in time? So what to do with these patients that at a certain point in time shift their hands, shift their option towards something different? They are asking you to provide them with different opportunities: maintenance immune therapy, RT-RBT, chemoradiation, and so what to do with these patients? They are contemporary patients in this setting. So bladder preservation strategies. There are multiple bladder preservation strategies. One of the latest advances in the field was made by Medgalski and the US colleagues that try to overcome the issue of radical cystectomy in responding clinical complete responders by continuing immune therapy with nivolumab in this case, instead of radical cystectomy. Or there are classical design of patient receiving chemoradiation plus immune therapy. A study like Keynote 992 is going to be presented sometime next year, later next year, I think. So the response-based flexibility is the key. Just to mention the possibility to avoid any radical local therapy, there are trials that have tested this paradigm. The RETAIN study was the first one in the United States. TURBT, chemo, and immune therapy alone, as I mentioned, provided intriguing data that suggested that clinical complete response was in relation somehow to the event-free survival or metastasis-free survival rate in this patient population. The data are still small, the numbers are still small, but that's certainly intriguing with the aim of shifting the paradigm. And the RETAIN study, as I said, the RETAIN will be soon released in JCO. The primary endpoint in RETAIN was not met, so that the possibility to provide or to meet the metastasis-free survival assumption was not achieved in this study. But anyway, when we look at the data, the results in deep in this study, you see that there is a proportion of patients who can benefit from chemo and surveillance when achieving a clinical complete response. There are heterogeneities in the definition of responses or complete responses for sure, so we have to work quite a lot on this, on the shared definition of clinical complete response in this patient. We are still at the beginning of the journey. The harmonization of the design of the study that based on the clinical complete response to incorporate clinical CR in the design of next generation studies. And what about adjuvant studies? Very briefly, you are pretty well aware of the studies that have provided outcomes thus far. The negative study, the negative results with Atezol, positive results for Checkmate and Ambassador with Nivo and Pembro. Nivo is for sure pretty well positioned because of the fact that it was performed and was tested in a global study, providing improvement in disease-free survival and also in overall survival in the update that was published a few weeks ago. The Ambassador study provided DFS improvement thus far, and it's a US-based study. So there is an issue of geographical heterogeneity that is affecting this study, but it's a positive study, you know, and the overall survival data are still maturing, are still pending. And finally, there is the possibility in the adjuvant setting to select more wisely the patient according to the according to the circulating tumor DNA, and ctDNA is another potential new wave for biomarker research for testing and selecting patients who may benefit the most from perioperative immune therapy. There are studies, in particular on the right-hand side, the modern study, PI is Medgalski in the United States, that are selecting patients for different adjuvant therapies according to the ctDNA status post-radical cystectomy. So the conclusions are already inside of my presentation. The most important conclusion is that patients have raised the bar for the success. So what we meant in the yesterday for the success was something like improvement in survival, event-free survival, and overall survival. For sure, this is a success today, and this will be the success for tomorrow research. But nowadays, patients are asking us to elevate a little bit more the rate of what we define success, possibly incorporating the possibility of keeping the bladder intact while meeting the endpoint of survival. So this is the next step for the research in this paradigm. And I would invite you to attend virtually our retreat that will occur next week. This year, the retreat will follow on Saturday 14 by a roundtable meeting with the FDA people and the EMA people, multi-stakeholder involved. Professor Dingweye would be one of the involved virtually in this meeting, trying to, again, establishing kind of a shared definition of clinical CR to use in the next generation clinical studies. These are the link for the YouTube live streaming that will occur on Friday and Saturday of next week. Thank you so much for your attention.
Thank you, Professor. Thank you for your excellent presentation. MIBC for urologists is a very challenging disease. Our goal is that we can keep the bladder and we want to make some achievements in keeping the bladder. In his presentation, he talked about neoadjuvant chemo and immunotherapy and ADC. He talked about different options. He also talked about some research. We can see very good treatment results. Of course, keeping the bladder requires consistent standards. We need to keep working on that, keep researching this. We hope that we can work on this topic. Thank you again, Professor.
I'm from the Medical Institute of Zhejiang University. I will be moderating the comments session. I will invite to the stage the first expert. I will invite all the experts to the stage first. Professor Zhang Xiaoping, Professor Hu Zhiquan, Professor Fu Qiang, and Professor Liu Nan. First of all, I will give the floor to the Director of Urology of the Tongji University, Mr. Zhang Xiaoping. Thank you for the invitation from Chairman Ye for me to participate in this event. The two presentations in this session is very befitting the topics of this session, transformation and thoughts. The first speaker, Dr. Fizazi, gave us an in-depth sharing on the radioligand theranostics in prostate cancer treatment. His presentation is focusing on Lu-177 and its efficacy in prostate cancer treatment. We have participated in two international multi-center clinical trials. Lu-177 and CRPC patients has played a very important role in the treatment of CRPC patients. These kind of treatment methodologies have enhanced PFS, OS, and also the progression of, and also the reduction in the pains and other symptoms in CRPC patients. Personally, I believe that in the future, this kind of therapy will be moved more early on in the treatment stages. In the report, we have seen that for mCRPC and hormone-sensitive patients, this kind of treatment can reduce bone pains and enhance overall efficacy. The second lecture from Professor Nechi focused on MIBC. Why MIBC is a focus area for urologists nowadays? There are two reasons. First, this kind of cancers are quite negative for the survival rates of patients. They lead to a lot of deaths. Second reason is that we want to keep the bladder. Keeping the bladder is a leading trend. What kind of patients can keep their bladders? And also patients have increasing demand for enhancing their quality of life. And for urologists, we have seen a lot of new tools and new therapies presented also by Professor Nechi, ADC drugs. They have less negative effects compared with traditional therapies. But if they're combined with immunotherapies, they can enhance the response rate by 60 to 80%. So this is a huge progress. And in the past, for MIBC, we will recommend the radical surgery. But in the past, we don't have enough attention to the quality of life of patients. So this is a very good presentation. In the future, in terms of maintaining the functions and keeping the bladder, T1, T4, what kind of customized indicators can be used to evaluate which patients can be keeping their bladders and how can we enhance their quality of life? Thank you. Thank you, Professor Zhang Xiaoping, for your sharing. And from Tongji Hospital in Wuhan, Mr. Hu, thank you for your invitation. Every year, we have this event, which is a carnival for the oncology field. Several years ago, we also learned about the radioligand therapeutics, the Lu-177, in this event, and also its use in bone metastasis, etc. And the clinical trials, more clinical applications have been used, which can reduce the 40% of death rate, which is a very good outcome. And domestically, we've also participated in a lot of trials. For example, at international level, we participate in the NOVA trial, and domestically, we have also carried out Lu-177 trials. So the international expert, Professor Fizazi, also gave us a lot of benchmarks. For example, he raised a lot of challenges. For example, the dose of Lu-177 and the intervention stage of the drug. So this should be taken into consideration during a treatment for MCRPC. And he also mentioned that MSPC, CRPC, bone metastasis, in these early on stages, can we move this treatment to these less advanced stages? And also for MIBC, the second presentation, the treatment of MIBC is a very hot topic. Keeping the bladder is a very key focus in China. In our hospital, we also conducted clinical trials, ADC, etc., and also neoadjuvant treatment is recommended by the guidelines and is widely recognized by experts. And we also add more precision-based treatment and chemotherapy, etc. So this can contribute to the keeping of bladder. Professor Nechi also mentioned a lot of problems. For example, PCR. After the surgery, the PCR is PCR just a CR. So the correlation is very important, and which requires more clinical trials and other questions. For example, after the surgery, does it require neoadjuvant treatment, immunotherapy, or chemotherapy? What kind of neoadjuvant therapies is required? So these are a lot of questions that remain to be addressed. After the new inspiration path, we also need to try to standardize the MIBC practices in the future. Thank you for the two very inspired presentations. Due to time constraints, please be brief in your comments. Next, I'll give the floor to Professor Fu Qiang from the Shanghai 6th Hospital. Thank you for your invitation, Chairman Ye and Mr. Chairman Dai. So, for example, I will share my observations on the radioligand therapeutics. It's a very important topic. We're doing the same trial. We used full compared with the Lu. So the full has less negative effects, but there are still problems. For example, the dose selected, and also how to label it, and also when to intervene with the treatment. CRP in the CRPC stage, can we use it in the CRPC stage, and also for and those other treatment, how can we combine it with other therapies? Thank you. And Mr. Liu Nan from Chongqing. Thank you, Chairman Ye and Professor Dai, for your invitation. I have two observations. First, Professor Vizazi talked about vision and Pro4. These have shown very good effects on MCRPC. The radioligand theranostics have played an increasing role in prostate cancer treatment. However, we've also seen that Professor Fizazi also talked about the resistance effects. Not all patients are sensitive to these treatments. What kind of what profiles are the patients that are sensitive to the treatments? Can we also use combination treatment, for example, radiotherapy, chemotherapy? How can we further reduce the negative effects and enhance its combined outcomes? This is the future for us, future exploration path for us. And also for MIBC, highlighted by Nichi, Nigara 4, there are a lot of neoadjuvant therapies, explorations. Overall, generally speaking, the combined treatment seems to be better in terms of efficacy than chemotherapy. But does it mean that all patients should be subject to the same kind of therapies? And in terms of ADC and new drugs that are used in the keeping of bladder surgeries, how can we select the best therapies through the screening of biomarkers, ctDNA, etc.? How can we screen the best therapies which are best targeted for patients? So this is my observations. Thank you.
Thank you for your comments, and thank you to our professors for your presentations. Now let's come to the next segment. We will have our roundtable. Let's welcome Professor Xing. I should stand here. Now let's invite our panelists. Professor Andrea Necki. Yeah. Can you give us the agenda? Professor He Chaohong, Professor Liao Hong, Professor Tu Xinhua, please come to the stage. We are already running late. This section is a roundtable discussion of a case. We will talk about bladder. This comes from urology from Fudan Cancer Hospital. This is 83 years old, and this was admitted for gross hematuria for 3 months. Let's see that there is a bladder mass. We suspect it's muscle-invasive tumor, right lower ureter, and possible right seminal vesicle involvement. In September, cystoscopy, 4-centimeter mass on posterior right bladder wall. October 7th, PET CT in another hospital. Hypermetabolic mass on right posterior bladder wall, and extending to pelvic mesentery and digital right ureter with hydronephrosis, multiple lung nodules with increased metabolic activity. and we blood test no abnormalities. The liver and the renal function normal. Past medical history, no surgical history or significant medical history. CTU, November. CTU, a mass on the right posterior bladder wall and a trigon. Suspected MT and with involvement of the prostate. Seminal vesicles, right ureter and the pelvic wall, right renal, pelvis dilation. Chest CT, multiple lung nodules, some suspicious for metastasis, and other conditions. October 7th, another hospital did a PET scan. You can look at the images and the involvement. We discuss the treatment first. Diagnosis: bladder cancer, CT4N0M1. Do you agree? Dr. Andrew, do you think the diagnosis is right? Bladder cancer, CT4N?
Yeah, but I would not overcome the need to get the re-2RBT or 2RBT in this case. So the diagnostic assessment and the histological characterization of the disease, also the possibility to get the confirmation that we are dealing with the pure or predominant urothelial carcinoma as compared to other variant histologies that may be important to know if they are present with regards to the definition of the systemic therapy is very important. So the TURBT is always important for us as oncology to have as a start point for the clinical workup of the patient.
Okay,
As time is limited, let's choose. We have 6 choices. Why do you choose this one, and what's your reason? This case is about bladder cancer. From the images, it's invasive bladder cancer. Maybe we don't have enough information about the case. We don't see the biopsy result. So first, we need a biopsy. No, you need to follow this slide, follow this procedure. Which one do you choose? I choose other treatments. I need a biopsy. Let's continue. As time is limited, let's go on. He's very experienced. Let's see. We did a turbot and cystoscopy. We have a 5 centimeter solid mass, and we see some blood, turbid urine with blood clots. And this is the pathology report, urothelial carcinoma. So there is some immuno situations. Next step, let's ask the other 2. Professor Liao, what's your choice? I choose D. Your reason? This year's guideline has been updated. And so we need to suggest immunotherapy plus ADC therapy. This patient is 83 years old, so I will definitely choose this as the front line or the only recommendation. Professor Tu, is C okay? If his condition is okay, I think C is right. Dr. Andrew.
Well, the answer is I don't know. My question to you is that is the immune therapy ADC available in China as frontline option?
Yeah, it's
for
available. Yeah.
You have the approval
yeah,
and the possibility. Okay. 83-year-old man. So another thing to consider is that for sure at the short run and the intermediate run, EV Pembro perform better than standard chemo followed by maintenance avelumab, you know. But you should consider the possibility for de-escalating a little bit the therapy for an 83-year-old man. EV Pembro means continuing EV pembro the long run as a maintenance therapy. So a huge charge also for the patient, for the hospital, for the infusion facilities, for the healthcare system, whilst chemotherapy and maintenance immunotherapy may provide a little bit more de-escalation. So I'm not sure that in all patient population, in particular in older patient population, EV pembro is the right choice for everyone. So we have to decide, and we have to take care of many information. For example, navigating a little bit more on comorbidities, pre-existing the cutaneous toxicity, ocular toxicities, diabetes, and so. And discussing with the patient the availability for sustaining treatment at the long run. So many factors may count into the decision-making process.
OK， 好，我们看看他们的这个。
Let's look at their choice. In December 11, they used tislelizumab and distamab vedotin. Intravenous infusion Q3W 4 doses, December 11 to March 4th. Side effects: gastrointestinal grade 1 toxicity and bone marrow suppression. Follow-up, March 23rd. Post-transthyreal bladder resection, the mass has reduced in size, but its boundary with adjacent tissues is still unclear. Let's look at the images. There is a reduction in size. The next steps in treatment. Do you continue to choose D or immunotherapy, radical cystectomy, or immunomaintenance? What do you choose? The treatment has been effective. In principle, I choose to maintain the treatment for another half year. I choose A. Professor Liao, just to choose, give a number. A. Professor He. I think after the treatment, the tuber has reduced in size. We need to do the cystectomy. But he's 82 years old.
There's a little bit of toxicity. So, and we don't know exactly what is the contribution of the two components towards the combination therapy, So also the option of continuing with the tail of maintenance immune therapy alone may be an option to consider.
So you chose A.
Yeah.
OK。我会看哈。
Okay. Continue immunotherapy plus ADC. We think this patient is 83 years old. He's very old. He doesn't want to have surgery. It's just my guess. But his condition seems okay. We continued to use the maintenance treatment, tislelizumab.
So since March 25th to May 10th, 2024, the use of tislelizumab was started, and then they used the CT scan at the thickening of the soft tissues in the right posterior wall, and triangular area of the bladder is roughly the same as before. The boundary with the adjacent tissues is unclear, and other situations are the same. The right kidney function is reduced. It atrophied as before. So next steps, so what's the next step? ABC, please choose, Andrew.
They disappear. Did they disappear?
ABC, you choose.
ABC, what do you choose?
The pulmonary mets that the patient had at the beginning prior to the treatment, did they disappear after treatment?
No, I don't know.
Okay, because we started with the metastatic tumor, so the consolidation surgery in patients started with metastatic disease is always very much concerning. So I would not opt for any radical treatment unless the patient is symptomatic for the bladder.
Okay, fine. Which one?
C meaning continuing systemic therapy.
Okay, fine. 那何教授
I believe that before if there's no cystectomy considerations, I believe I will choose B. We will continue to use drugs. The mass on the lung, on the pulmonary masses, we don't see the conditions on that, the changes on that. So for immunotherapies plus ADC, if the reduction rate is above 60%, and you will see the imaging also suggests that, I believe that the cancer is active. So I choose B. Which one do you choose, Professor Tu? I choose B. Yes. So it is. He's admitted to hospital for TURBT on May 25th, and you see pale and stiff mucosa was found on the right posterior wall of the bladder, and no obvious lesions were found in the rest of the bladder mucosa, and urine spray was seen at the left ureteral orifice, and the pathology outcome is chronic inflammation of the mucosa. You don't see any cancer tissues. So next steps, Professor Tu, what do you choose? A, B, C, D. Now, clinically speaking, it's a CR situation. I believe that we will continue with the treatment, ADC treatment, and immune therapy. So I choose B. Professor Liao. This patient, I believe we should go with A, immunotherapy maintenance. Professor He? I choose A. Dr. Nechi?
I would opt for. I would be more happy to provide the immunotherapy alone, but a better tolerated therapy. So A.
okay.
So maintenance therapy started on June 17th. So we have more or less a consensus on that one. So it started from June 17th, the tilazumab and by intravenous Q3W for a total of 3 times. Side effects is none. And then again, CT scan on August 13th after the cystectomy, the right posterior bladder wall and triangular soft tissue thickening is roughly the same as before. And the boundary with adjacent tissues are clear, same with the previous CT scan. And you see after 9 months of treatment, what should be the next step? Andrew, what do you choose? Andrea?
Interrupting therapy. So 9 months is too early. We usually consider 2-year period of treatment prior to think about interrupting therapy. So definitely A. I will continue with immune therapy.
You prefer A? Okay.
Professor He? I believe A is the choice. Professor Liao, I know that you would choose A. So what should be the frequency of giving drugs? I believe that we will continue with immunotherapy maintenance. We should not stop ADC because with the toxicity, we cannot continue with the ADC. So how do you give the drugs? Every more than 1 year, 21 days, every 21 days. So we'll continue with this standardized immunotherapy. Yes, I choose A2. Okay. Then maintenance therapy with tislelizumab started on August 26th and all the way to October the 28th. There's no side effects observed. And not long ago, the CT scan was already conducted. The outcomes are pretty much the same with previous ones. The left kidney had a small cyst, same as before. There's no suspicious metastasis. And then again, you will see that ultrasound re-examination in November, slight thickening of the posterior wall of the bladder, right kidney, atrophy, no obvious mass in the liver, and also chest X-ray recheck was conducted, increased texture in both lungs, scattered small nodules in the left lung. There's no CT examination. I don't know if the resolution is worse. So next step, what's the next step after Now, 1 year of treatment, what will you choose? Lao Tu, Professor Tu, would you choose? After 1 year of immunotherapy, we can observe for a while. Follow-up observation. I choose C. Professor Liao choose C. I also choose C. Andrea?
For us is that we don't know. Maybe A, as I mentioned, we usually consider, but it's an empirical assumption, that 2-year period is sufficient, sufficiently long to consider the potential for interruption therapy in patients to achieve a deep response. So I would consider it a bit more, continuing therapy, immune therapy, but it also depends on the patient, on the logistical issues.
A.
Yeah,
Okay,
still a bit more.
Okay, fine. 那所以这个还是
Yes, Andrea, you got the right choice. Immunotherapy. So after 1 year of treatment, continue with the maintenance therapy with the tislelizumab started on November the 25th. So you see that after this treatment, this is the first TURBT pathology of UC, and after 1 year of treatment, he will continue to do the maintenance of immunotherapy. So, personally speaking, the maintenance of therapy should be conducted over a period of 2 years. 1 year is a bit too short. Okay, thank you for this very inspired discussion, and we're 2 minutes in advance, so thank you.
Thank you, Professor Xing, for moderating the previous session. Now let's come to the case discussion of prostate cancer. Now let's invite Murphy, Professor Murphy, to talk about the progress in surgery, and then other professors will come to the stage.
Thank you very much again for the invitation. Professor Ye has asked me to speak about robotic radical prostatectomy techniques. And of course, I'm a full-time prostate cancer surgeon, and I always enjoy hearing from colleagues about their techniques. So I very much look forward to the discussion afterwards. Also, I thought I would, oh, we're waiting for slides, yeah. I thought I would acknowledge the long friendship I have now with Professor Ye here at Fudan University Shanghai Cancer Center, and many of you. I first visited here 10 years ago, and I came to this symposium in 2015 for the first time. Dr. Friedland is there on the picture as well. Dr. Chariot, Yao Zhu is there. And that led to us signing an agreement between my cancer center in Melbourne and with the cancer center here at Fudan University. So we're celebrating 8 years of that arrangement, which has been very, very productive for both institutions. We've had many collaborations back and forth with visits to China and to Melbourne. There are some photographs here, and myself and Professor Ye at the Lugano meeting, APCCC, this year, and on our podcast as well. So I very much value the friendship and the collaboration. So I have 4 short areas, my favorite parts of robotic radical prostatectomy, to share with you briefly over this time. But we should also know that I only do Da Vinci surgery, but I'm very, very excited to see these Chinese robots coming. Here's a TikTok we posted in September when I got to see the Edge medical robot for the first time. It was on display at the UAA meeting in Bali in Indonesia. It looks like a very impressive piece of equipment. I sat down and played with it. It feels very familiar to me as a Da Vinci surgeon. And during that meeting in Bali, Edge Medical sold 4 robots in Indonesia. And Intuitive had sold 1 robot in the previous 20 years in Indonesia, a country with 250 million people. So it's exciting to see these robots, which look very impressive indeed. At the European Robot Meeting, we discussed with Professor Alberto Breda, who's the chief of the European Robot Meeting, on the podcast about his experience. He did a telesurgery between France and China, using the robot in France and the patient in China. So we are at the start of this very exciting wave of robots coming from here in China. The other one that we featured recently on the podcast at the European Robot Meeting was from here in Shanghai, the Medbot Tumi robot. We discussed with Alex Hay, who's the president of that company, about his vision for how that robot will expand across the regions. And this, again, feels like a very impressive, very familiar robot for us to use. So we're excited to see these robots are now CE approved, so can be accessed in Europe and many regions like Australia. And of course, as we heard from Professor Ye this morning, we have multi-port robots and many other robots coming out of China. So today I'm speaking about Da Vinci surgery, but I very much look forward to being able to have experience on using robots coming from China very soon, I hope. I really enjoy speaking about the bladder neck, and when we train our young trainees to do robotic radical prostatectomy, the bladder neck for me is one of the most important areas to focus on. We acknowledge it can be one of the more difficult parts of the surgery, and the learning curve can be quite long. And our friend John Davis wrote about in the early era, before all these videos became available, how it was difficult to figure out how to do the bladder neck. And my message to the trainees is, you can get into a terrible mess, you can have terrible trouble at the bladder neck, and it's completely avoidable with good training and good technique. My simple advice I give to trainees is, number one, I'll show you now, define the bladder neck thickness, and then number two, just maintain the bladder neck thickness. Follow the bladder and you will reach the posterior structures. Don't follow the prostate, that's where the trouble starts. So here are some examples, and of course having MRI widely available really helps us doing a nice job on this case. So before every surgery we look not just where the cancer is, but what does the bladder neck look like? And in a small normal prostate like this, we can see that the red line is showing a very straight plane. We can go straight down the back of the bladder neck and there will be the posterior structures. And so you'll see that here for a few moments in this video. We like to pull on the catheter to maintain the bladder neck awareness, but as we enter the bladder neck, you'll see that we are being very careful to look inside the bladder neck and appreciate the thickness of the bladder neck. We hold it up with a catheter like that. I'm feeling with the instruments the left side and the right side and trying to make sure we keep an even thickness on the bladder as we do this dissection. So this is an easy one, a small one, but when we train people, we emphasize it's really important to have good technique on the easy cases. So when we have more difficult cases, we have this technique very, very well prepared, maintaining the thickness. So I'm constantly looking inside to make sure we're keeping the thickness. We're not getting too thin or we're not getting too thick, because either of those mistakes can lead to problems in more difficult cases, as we'll look at in a moment. So keep checking inside the bladder and make sure the thickness is maintained. This helps avoid having a buttonhole entry into the bladder or indeed being too thick. So what of this example then? So now we have a small median lobe, which always adds a little bit of difficulty. The bladder is now draped over the median lobe. So when we look from the side, it's no longer a straight line down the back. We have to be careful because this line that's going down the back can lead to a potential buttonhole here. So we have to be very careful in these cases of a median lobe or a very large prostate. So we have the same approach. We're pulling on the catheter to see where is the anterior bladder neck, but of course the risk of injury is really in the posterior bladder neck. So we try and enter here in the midline and identify the median lobe here. It's very important we look at the shape inside in case we see a very deep cave, if you like, as the bladder descends under the prostate. So again, we're constantly assessing the bladder neck thickness in the midline and also on the left and on the right by putting our instruments inside the bladder and feeling for that bladder neck thickness. I don't mind in big prostates or median lobes if the bladder neck is a bit wide. It's better to do that rather than have it very thin. You can see my instrument is going inside laterally because that's a good way of assessing the bladder neck thickness. So it needs to be the same, so you don't have a buttonhole, an entry into the bladder on the left or on the right, as we see here. And yes, you can use the fourth arm to lift up the median lobe or the big posterior portion in a big prostate, and then still be very meticulous in how we keep looking inside, look inside, look inside. And that will prevent us having a buttonhole injury at the back. So here then is an example of a difficult large prostate. This is 130 cc, so we can see a big adenoma. We can see it's a long way down the back here, so this will be a deep dissection. So the prostate is bulging out here and filling the pelvis more. As we pull on the catheter, it's barely reaching the prostate. So we pinch in like this as well. We take all the fat off the bladder neck as well to help us identify the best place to enter. These big prostates always bleed more. So when we have a prostate more than 75 cc, we're constantly going to see bleeding like that. And so I always tell the team, don't worry, it's not going to look as pretty as a small prostate. But what's very important with these big ones is to try and avoid a difficulty in the posterior bladder neck. Avoid a buttonhole, avoid a ureteric injury if you have a buttonhole. And the key is still very simple. Follow the bladder. Keep a close look on the inside of the bladder. You can see my instrument pushing inside, left side, right side, which is assessing the thickness of the bladder. Not visually, because we can't see inside left and right, but we can feel the thickness by doing an instrument push inside. And of course, they will always bleed a little bit more, and then it's even more important to maintain that bladder neck thickness. And no matter how deep and how big the prostate is, if you simply maintain the bladder neck thickness by keeping looking inside, then you will hit the seminal vesicles and the vas exactly right. Whereas if you are following the prostate, it's possible you'll be very thick and you'll miss the seminal vesicles. Or if you don't be aware of the thickness of the bladder, of course, you can have a buttonhole, have an injury into the bladder neck posteriorly. Another challenge, of course, is previous TUR. And again, we can see on the MR that this is a patient with a very wide bladder neck. As we pull on the catheter, it's pushing up inside the prostate into the TUR defect. These cases usually end up with quite a wide bladder neck so that we can identify the correct place to do the posterior incision. And as we enter in here, it's very variable depending on the TUR, but we often have a bit of difficulty in identifying the true bladder neck because it's been resected previously. So it is important to see the ureteric orifices, as we see here, because they also may have been resected previously, depending on who did the surgery. So previous TUR, it's always very important to see. So therefore, don't be worried about making the bladder neck very wide. This can always be easily repaired. And then you can make a better judgment about where the posterior incision should go. So my tips on the bladder neck: follow the bladder, not the prostate. Be aware of the large prostates, the median lobe, the previous TUR. It will be more challenging. So if you're early in your learning curve or you're a trainee, try and avoid those cases or have some experience. MRI is great because now we get a heads up, but if you don't have an MRI, I would just be careful to open the bladder neck adequately to make sure you're not missing a large thing. So nerve-sparing surgery, of course, we're always trying to improve our nerve-sparing technique. I certainly am always trying to improve my nerve-sparing technique by watching other experts. I'll show you just a couple of minutes of a typical nerve-sparing case. I've selected this case because this is a 67-year-old who did have very good return of his sexual function after we did his surgery. He had favorable looking cancer. You know, his MRI was normal, minimal avidity on his PET scan. So we know that there's no real risk of a positive margin in the posterolateral planes. And indeed, that's exactly what his final pathology showed. So in this case, we are staying inside the Denonvilliers fascia as we go down posteriorly. We've lifted up the seminal vesicles. I use a 30-degree down lens, which I move up and down depending on which part of the surgery we're doing. So here I think I've got it in the down position, but you will see me adjusting the lens so that we can look upwards. And I think the 30-degree lens is a great advantage for doing nerve sparing. I use metal clips for these cases, whereas I use Hemolock clips for non-nerve sparing cases. And you'll see we're constantly adjusting the traction and counter traction, and the assistant is bringing in the metal clipper. So I tend to do a lot of this from underneath rather than releasing the nerve bundle laterally. This is how I observed the team at the Martini Clinic, who are the most experienced radical prostatectomy center in the world, doing both their open surgery and their robot surgery. So while I will open some of the nerve bundle laterally so I can appreciate the shape of the prostate, I tend to actually do the definitive part of the nerve sparing by looking underneath. So here we are, we're lifting this up now and we're concentrating on getting a metal clip close to where we think the closest possible margin will be for this case. And again, avoiding electrocautery is obviously a good idea, but it's okay to use small little bits of bipolar energy in my view, or even a tiny bit of contact monopolar. And as we proceed underneath here, I tend to move between the right side and the left side as each side becomes a bit more mobile. And as I say, once we use a 30-degree lens and we move around the side, it's very helpful. You can turn the lens so you're sort of looking underneath the prostate, and you can stay close to the prostate as we approach the apex, as you see here, which number one will maintain a good nerve sparing plane, but also that's a good idea to minimize your risk of a rectal injury. Rectal injuries tend to happen in that position up at the apex laterally. Now we've turned the lens upside down, so it's 30-degree up, and we're directly underneath the prostate, and here we are stripping the nerve bundle inside the Denonvilliers at that point. I do switch back to the 0-degree lens. That's why I showed you there on the video. We change lens back to the 0 when I'm at the apex. I like the 0-degree lens once we're looking straight down the front of the prostate. I don't ligate the DVC up front. I just cut the DVC once we've fully mobilized the rest, and then all we have left is the urethra and the DVC. So that's what we'll see here now. We bring in the catheter. It's very important to have the catheter in for doing the apex. I do bring in a V-lock suture, so that's ready to go. And I won't show you that part. Well, we've done it. We've finished the dissection, and this is the final result on this type of case where we've got two nice bundles. And as I say, I choose this case because this patient had an excellent result from his surgery. What about problems? What about difficult cases? So this is back when we used to do a lot of pelvic lymph node dissection. This is the end. We thought we'd done pretty well, but there was a little bit of oozing. And, oh, it's not a little bit. There's quite a bit of bleeding, actually. You know the way sometimes at the end of the case you see a little bit of oozing? Let me just have a look down there, and then you realize there's actually quite a significant bleed coming from the internal iliac vein, probably. Always first thing I do then is bring in a gauze swab, Raytec swab we call this. It's very good just for getting a bit of pressure and a bit of control on it, maybe while you get a stitch ready or have change over to some needle holders. And then with your assistance, you can roll that swab back, just like we would do with open surgery. So do not just go in there with diathermy in the lateral wall of the pelvis where you can create more problems. Instead, we use a mixture of local pressure with the swab and good suction. And then sometimes you're better off going back and dissecting from above downwards. Go back even up to the bifurcation and follow the internal iliac artery and vein down and find that hole. And if it's a vein, yes, we can either choose to clip it or we can oversew that with a suture. Finally, last year at this meeting, I sent a video just talking about salvage prostatectomy, but we get a lot of questions about that because I do a lot of these cases. So I want to show you two examples. One is a bit different. This is a classic salvage case after brachytherapy. You can see on the PET scan here that the patient's got an area of avidity like so. But also on the PET scan, you can see that there are seeds outside the prostate. So this always spells trouble, of course. This means we will have difficulty because quite a dose of radiation will be in the adjacent tissues. So here we are dissecting down the right side. This is where the endopelvic fascia is on the right. We're seeing brachytherapy seeds out here in the endopelvic fascia. and all this terrible fibrotic radiated tissue at the levator ani as we approach the apex. And this is why these cases can be both difficult, but especially why they have problems healing afterwards. This is all very unhealthy looking tissue at the apex on the right side, and we can see why. There are brachytherapy seeds outside the prostate all over the place here. And as we go through the apex, through the DVC, yes, we're still cutting through brachytherapy seeds at the apex, which of course is where we're going to be depending on the anastomosis. This is why we have to warn about the risk of stricture formation in these cases, because if there's been a big dose of radiotherapy to the apex, in the membranous urethra, in the pelvic floor, unfortunately, that is going to be unhealthy tissue for which to heal. I don't have any great tips for how to avoid that. These are difficult cases. In last year's lecture, we spoke about how we select patients, what we tell patients, and we spoke about some tips and tricks for that. In Melbourne, these cases tend to be done by only 2 or 3 of us who have a lot of experience doing these cases. And yes, I think if you haven't done a lot of salvage prostatectomies, please send them to somebody who does, because they'll be like me. They'll have a lot of experience of the complications of this surgery, which is helpful. And these are all the seeds in that case that I removed from outside the prostate, like you saw there, 17 seeds that weren't even in the prostate. And this is his cystogram 2 weeks later. I always do a cystogram after salvage prostatectomy. And look at all the seeds that are still in the body, unfortunately, afterwards. So that's why some of these patients do get a lot of adjacent morbidity. And by the way, on our podcast a couple of months ago, we spoke with Paul Cathcart, who's a very nice urologist from Guy's Hospital in London. He did a fellowship with me many years ago, and he's extremely experienced in this salvage prostatectomies. He's done more than 500 salvage prostatectomies in 10 years because he gets referred all the focal therapy cases from around London. So on this podcast, he gives a lot of tips and tricks about salvage prostatectomy. The final one I want to show you is a little bit different. So this is a paper we wrote in 2020 about our experience doing robotic prostatectomy after failed open prostatectomy. So these were patients who had open prostatectomy planned, but for whatever reason, the surgeon had difficulty with the open prostatectomy, so they abandoned the case, close up the patient and sent it to us. We did 6 of these cases over a period of 2 years. Mostly they said because the pubic bone was very low, or the patient was obese, or they had a lot of bleeding when they were trying to do the dissection. And here's one of those patients. You can see that the abdomen is not blowing up correctly. You can see that there's a bit of a dimple here where the scar is, where the retropubic scar is. And there's a video that accompanies this in this BJUI paper. And you can turn down the audio if you can, thank you. And as you'll see here, when I'm mobilizing the bladder, you can see this very dense adherent scar between the bladder and the retropubic region where the incision was. And I think these patients usually haven't just had an incision, they've also had bleeding and fibrosis, so it's quite difficult going in here. Most of these cases we did, it was 3 or 4 months later before we did them, but one of them we did it 3 days later. The patient was still in hospital in one of our private hospitals, so we just took him back to theater 3 days later and did it. So yeah, we've reported this experience. You might think it used to be the other way around. If you can't do it with the robot, maybe the open surgeons can do it. Now it's actually the other way around. If the open surgeons have a problem, yeah, send it to us and we can do it with the robot. But it's not easy. This is like not pleasant surgery. We'd prefer to just do them first time around with the robot. So it's different looking tissue to the salvage case I just showed you. It's more so the scarring in the retropubic and endopelvic fascia region. Because they haven't had, of course, the radiation. You can see all the dense scarring in this particular case. Yep, so these are my final tips that I've been talking to you about through this case. And as I say, I'm very much looking forward to, in coming years, learning from your experience of using these new Chinese robots and hopefully in my own center, getting access to some of these nice systems ourselves in coming years. Thank you very much.
Thank you, Professor Murphy, for this presentation. Now let's invite 4 speakers to the stage. Let's come to the next part of the discussion of the case. Let's show the slides. Dear experts, good morning. Here I would like to talk about a 72-year-old male, PSA 77.42, enlarged prostate, and abdominal signal focus, and a Gleason score 4.4 plus 4 equals 8, and prostate 2-degree large, and diabetes for over 10 years, fasting blood control very good, and abiraterone plus prednisone. This is MRI, and this is very obvious. We did a PSMA PET. It shows that they're closely related to the rectum, but no obvious high expression lesions seen elsewhere. So his grading is CT4N0, M0. So which treatment do you choose? Let's start from Professor Jiang. What's your choice? What's your recommendation? This patient is 71-year-old male. So he's a high-risk patient, T4. And we did some evaluation for such a patient. I remember he already used abiraterone. You didn't mention how long. Maybe less than 1 month. Then I choose neoadjuvant plus radical prostatectomy. Professor Yao. In open surgery era, I would have chosen A. Now, we want to be more precise. We want to reduce complications, so I choose B.
And how about your choice?
I would talk to him, but I would probably lean towards E, other, which would be radiation therapy.
Okay, so you will consider radiation combined with the ADT for this patient?
With ADT plus abiraterone for 2 years. Yeah, I mean, radiation, the best data we have says radiation is equally as effective as surgery. We have a randomized phase 3 trial. Survival, prostate cancer survival is the same.
Okay.
So, I mean, you know, I defer to Declan and others, whether it's even surgically resectable. But to me, why do that for this one when radiation is a very good option for him?
Okay, so how about Professor Murphy, your comments?
It's a great case, isn't it? Because we have two very good options here. I think we have to first presume it is resectable. It's probably not T4. It looked more like a T3 to me, and it's had a bit of ADT. So let's presume it's, you put your finger in and you think I have a reasonable chance of getting it out with a negative margin. But on the other hand, his PSA is 77, and he is 71 years of age. And the likelihood of him being cured by surgery on its own, we have to say, is low, I think, or not high. So it really depends on the patient. If this is a super fit 71-year-old who's highly motivated for surgery and accepts that he might still need radiotherapy, I think surgery could be considered. But on the other hand, he will get excellent control with radiotherapy and ADT plus minus an RP, and you'd have to say that that's a very high standard of care for most patients.
And I would just add, if you are choosing, so if we assume it's T3 and resectable, then I agree, dealer's choice, you can discuss. But if you do radiation, we have level 1 evidence that adding abiraterone for 2 years to the ADT improves overall survival. So you said plus minus an RP. Yeah. For me, absolutely it's plus.
Another point I might make is that, you know, in the UK, in Stampede, they would consider this to be their so-called high-risk localized prostate cancer because he's not metastatic. And they, you know, their original trial was showing ADT plus ABI versus ADT alone, the so-called high-risk non-metastatic trial in Stampede. And I would just say that we should never do that. You should always offer radiotherapy if you're going to do ADT and ABI. But that so-called Stampede high-risk localized, so PSA above 40, Gleason 8, T3, you know, 2 out of the 3. Yeah, you must not do systemic therapy only, I think. It's very important to do some local control.
Correct, and almost everybody in that trial did get radiation. But I agree, I think we have other data. Systemic treatment alone is the wrong answer.
Thanks for your comments. So, Murphy 教授和这个
Murphy and Freeland mentioned that they would like to talk to the patient. If there's radiotherapy, radiotherapy is something we can choose, but medicine alone is not advisable. We need to have local treatment. So this is a very good, important piece of information. We know that many patients may choose surgery. So we have chosen abiraterone and goserelin, and we can see the new situation and the shrinking. And this patient has a strong wish to do the radical therapy. Then we did a surgery. If we perform a surgery, then PSMA PET has no lymph node metastasis and has a local high-risk situation after abiraterone. What surgery plan do you choose? Let's start from Professor Murphy. For such a patient, PSMA PET negative,
therapy and have strong willing to surgery. So will you provide lymph node dissection or extended or only radical prostatectomy for this kind of patient?
Well, you know my answer from my previous talk, but I'll emphasize one of the important reasons why I think in this case I would only do a radical prostatectomy. It's because he is highly likely really to need radiotherapy. And you know, the morbidity of radiotherapy into the pelvic lymph nodes after they've had a node dissection compared to they've had no surgery in the lymph node basin is much less. And our radiation oncologists will consistently say that. And because there's no evidence that doing a lymph node dissection improves survival in this 71-year-old man, I would say here in this case, if he's having surgery done by us, we would only do a radical prostatectomy. And then if and when he has biochemical recurrence or lymph node involvement, he'll do very, very well with pelvic radiotherapy. That's my personal view, but I'm aware that in the room, many of you will say, no, this patient should have a pelvic lymph node dissection. And I understand why it still should be considered, but I think the evidence is really switching strongly away from it.
Okay, so how about Steve?
So what I would say is I would not do B. And then the question is, I think if you're going to do it, you do extended. And then the question is, do you do it? My practice has been to do it, but I think Declan makes some very good arguments why not. For me, I do think it is prognostic, though we clearly know he has a bad cancer, but he's responding well to the treatment. So he's got some good factors, some bad factors. I would probably lean towards C, but again, I think Declan makes some very good arguments for A. I would certainly not do B.
Okay, so 因为我们这个姚教授和
Professor Yao and Professor Jiang are experts on PLND, so what's your choice? For PLND, well, there's a EAU guidelines have highlighted that there should be EPLND for high-risk patients, but in clinical settings, more patients might select RP plus standardized PLND, and also autopsy PLND. So the staging is very important for endocrine therapies. the survival prognostics of these patients are quite good. Even though Gleason scores might be quite high, but if you do EPLND, they will not get more benefits. So I choose B. Well, this patient is a very high-risk patient because he's a quite elderly patient, as highlighted by our expert. So if he has 10 years of expected lifespan, so this might be part of the systemic treatment. In the past, Professor Zhu also said that these kind of patients in the past we would do EPLND without a doubt because it has some treatment effect. But over the past 1+ years, because we have PISMA PET-CT tools, for these patients, we use a precision-based diagnosis. Diagnostics have been enhanced. So if on PISMA, there's no signal of a lymph node metastasis, or metastasis is very localized, very small, then we would choose A. We will choose A, the RP, and then in later stages, we will use radiotherapy. So this is my choice. Thank you for the 4 experts. I will do a quick summary. So they have all highlighted very good suggestions. Professor Morphy and Professor Jiang all mentioned that if you don't do PLND, then you can do adjuvant radiotherapy, then the bad effects will be controlled. MDT tools have been evolving, and we can use negative margin surgery. And Professor Freeland also mentioned that PLND is a prognostics value and not a treatment value. And also in clinical settings, we will. There's a lot of discussions in terms of the overall quality of life and survival. And so for those various PLND and IRP surgeries, the dissection scale is quite normalized. And then after the surgery, the PCR, and after the pathology, you didn't see any metastasis. So for these patients, he recovered well. So there's no standardized choice, but in clinical setting, we might choose regular follow-up. We might use endocrine therapy or abiraterone, prednisone, IDT. So what will you choose, Mr. Jiang, Professor Jiang? Well, I might have 2 choices, but there's only one allowed. So for this patient, you need to engage in in-depth discussion with the patient. I would choose D. The life expectancy is quite long, so he requested for RP. So in earlier stages, there are more tools to do a radical intervention, and the outcomes might be good. But we will see in terms of its PSA changes for later interventions. Professor Jiang talked about how we should engage and in exchange with the patients. It's true that various tools have trade-offs. So from the perspective of the patient would also want to know the ideas of doctors. I would choose C from a conventional treatment view. Stephen.
To the best of our knowledge, the patient is cured. NED is the complete response with neoadjuvant ADT and an RP is 5%. Very low, and he falls into a very good prognostic group, we think. And at some point, I think you need to stop therapy and see if it worked. And if it didn't, you'll see the PSA will come back quickly. Once the testosterone goes up, you'll see the doubling time is short. And then at that point, we can do ADT and enzalutamide, we can do radiation, but at a certain point, there's a chance this patient's cured, and we need to give them the chance to test that idea.
Yeah, I would stop his ADT and his ABI and just watch the PSA because it's a really good marker after surgery to see where are we. And it'll be 6 months or a year before his testosterone recovers, and it's a chance for him to get quality of life back with his, he's kind of got diabetes or pre-diabetes, so stay off the prednisone. And you still have all these things available in the future if he becomes metastatic or if he becomes high-risk BCR. He'd be a classic one that Dr. Friedland spoke about earlier, a real embark patient in the future. But he might get 5 years off systemic treatment. So I would argue for just the PSA.
And just I want to make one quick comment. We're seeing in study after study in metastatic, high-risk biochemical occurrence, radiation, that ADT is not good enough. If someone really has such bad disease to warrant all the side effects of being castrated, we should do it right. So for me, I'm not a fan. If you are going to treat, it would be more something like D or Enza or something. I don't like the ADT alone. It's like some treatment, but not great treatment.
好，非常感谢这个我们4位。
Thank you very much for your inspired answers and interpretations from the evidence of the clinical settings. You will see that EMBARK results have all indicated that if you use ADT treatment, you will need intensified endocrine therapies to have better results. And for post-surgery patients, you will need to monitor the PSA levels to see the changes in his situation. So this is a window period for us to evaluate future therapy choices. So I would like to thank again for the 4 experts here present for their very insightful observations and comments. Now please take your seats. Please take your seats. We will move on to the next session. Please show the slides. Next slide, we will be talking about renal cancer, and Ms. Zhang Aili will be moderating. First, I will invite to the stage the experts to the stage. Mr. Axel Mosberger, He Zhisong, Mr. Jiang Haowen, Mr. Hu Denlong.
好，那么咱们这个环节的内容是肾劝在握一个肾癌复杂病例的处理啊。首先，我给大家。
Let's talk about some of the cases in kidney. So, female, 40 years old. In May, there was a large tumor in the left kidney, and multiple nodules, metastasis is suspected, and then a laparoscopic cytoreductive left nephrectomy. And for such a patient, we did a surgery, a treatment, and it's intermediate risk, so we must have some treatment. So which treatment is the best? Please give us your opinion. Which treatment strategy should be recommended? So there is a metastasis in the lung. So IMDC is intermediate risk. Then targeted alone is not enough. So there is some choices abroad, but I think we can do number 4.
I would decide between 3 and 4 because we just have small lung metastasis to my knowledge, and we have some time. So also in intermediate, we would have data for IO treatment, but also option number 4, treating with a potent TKI combination with axitinib and IO would be a good option, for example.
好，江教授。
I choose 4. We did a clinical research on number 3. The adverse effect was very big, so I usually avoid the number 3, so I choose number 4. Thank you. I think that, people choose 4, and I think I agree with that. And this person has lung metastasis and other conditions, so we can use neoadjuvant or number 4, and then surgery or a delayed dissection of the kidney. But after surgery, I think number 4 is the best choice. Let's continue. According to our guideline this year, so for intermediate patients, we choose number 4. And we can also use targeted treatment alone. The EAU guidelines recommend combined therapy. We are clear of clear study, and it shows that PFS and OS have benefits. So the patient was treated in another hospital in 2022, and we used lenvatinib and pembrolizumab. And then, according to the PET-CT, in the surgical area and other area, there was soft tissue lesions with increased metabolism, and there are many nodules. The disease is progressing. So now we need second-line treatment. So what's the choice for second treatment? The CLEAR study, it's a very good treatment, but for China, the resistance is very, very bad, and the East Asian people have this resistance. We don't know why the disease progressed so quickly. So now that the disease has progressed, we should have choice number 6. We should have this patient in a clinical study. If the patient cannot enter any clinical study, then in the real world, I would choose something not on the list. I would choose a Chinese drug and therapy. We can change the target. And in China, Furonibu and another drug are your choices after a failed targeted therapy. And its mechanism is different from pembrolizumab, and it's better for the patient. But if I'm forced to choose from the list, I will choose number 4. But in China, this is not accessible. Dual immunotherapy is not accessible in China.
So I really like the professor's comment. Number 6 would be my preferred choice, a clinical trial, if possible. However, also number 4 would be interesting, but we don't have approval in Europe either. It's not. It's only in first line. So I think another potent TKI, like for example axitinib, would be approved and in label in Europe, which would be also a EAU recommendation. So the other option would be number 5. So I think I would switch. I would discontinue pembrolizumab and I would switch to another TKI and hope for some response.
OK， 张教授。
Professor Zhang. So for me, if it's my patient, I wouldn't treat him this way. In the beginning, I think we started on the wrong step, and we keep making wrong choices. In this stage, the 5 are not different. We can expect the outcome. If we have to choose some, I will choose number 3. I will consider the economics more. I don't want to spend money uselessly. I agree what they have just said. I think number 4 may be better recommended, but in reality and in terms of accessibility, the pembrolizumab is more accessible. It's more economic and more realistic. So let's look at how the patient is treated. According to the CISCO guideline, we suggest clinical research, and then we can have some targeted medicines. This is the recommendation in China. EAU says that you can change the targeted drug. You can choose something you haven't used, and then plus immunotherapy. We've seen the different second-line treatment options. Levantinib and everolimus is good, but it's not very safe. And cabozantinib is good, and its side effects are less. Let's focus on this patient. In December 2022, he switched to the targeted drugs. After 3 months, the assessment is not very good. The MRI shows that there's multiple soft tissue nodules with enhancement in the left abdominal cavity. So it's not very good. And then there seems nothing we can do, but how can we treat this patient? So some summary of this patient's information. Female, 40 years old. So T3 ANXM1, stage 3, intermediate risk, and clear cell renal cell carcinomas, and disease progression after 10 months, systematic therapy, TKI plus PD-1, and the 2 drugs for 7 months, and then another 2 drugs for 3 months. Now, multiple focal metastasis to the lung, liver, and it's a very serious situation. It's the lung metastasis, the nodules, and liver, many metastases. Next step, how do we treat this patient? We think it's a very difficult choice. We have several options.
There's no standardized use of drugs in second line or first line. I believe that first we need to use targeted and immunotherapy, the MTAR plus fronimabab. So when you have liver metastasis in multiple lesions, you need to use more intensive drugs. For targeted therapy, you use cabozantinib. But for immunotherapies, some people believe that after the combined therapy failed, then you can use immunodrugs alone. But 2 trials have similar outcomes that have pointed to less effective outcomes. So does it mean that different immune drugs are different? After one failed, you can choose another one. For first line or second line, they all use cabozantinib. But we can probably choose another immunodrugs, the PD-1 inhibitor, PD-2 inhibitors are also available domestically. So I believe that targeted and immune therapies should be first line, and then you can also choose other PD-1 and PTL1 inhibitors aside from cabozantinib. Yes, you might need to change therapies, right, Ms. Berger?
A very young patient here that has failed on 2 TKIs, namely lenvatinib and axitinib, and also failed on IO treatment with pembrolizumab. So I don't suspect that we will have a strong signal on switching to another. So if it would be my best friend, I would try to convince the payers and the insurance maybe for CTLA-4 inhibition ipilimumab. I know there's not a lot of data, but this is the only mode of action this patient has not seen yet. Otherwise, I agree with a colleague, cabo would be a try. Cabozantinib, we have some good second-line data, and maybe even considering mTOR, which has a label even in monotherapy. And now recently we have seen data from HIF2 alpha inhibition belzutifan, which in some countries has a label. So I think this might be also an option. So I would go for maybe 5. Thank you.
好，感谢。
Thank you very much. Yes, so you might need to change a bit of the drugs and therapies. So from this perspective of a disease, you can choose either one, but from his personal situation, you might think of the financial situation, psychological conditions to help her lead a better life. The negative effect of all these drugs might be even larger than a non-treatment. So for all these treatments choices, if you don't take into account his personal situation, so it doesn't matter which treatment you choose. So we are on a wrong path, I believe. Professor Jiang is quite negative. So Professor Mo, I believe with the previous 3 speakers, it's a very difficult choice. Now you're at the 3rd line treatment. The scope of maneuver is very small. She's only 40 plus years. She has a strong desire to survive. So at this point, and also the progression of the disease is very fast, so we need to be proactive in the change of drugs. For example, the change more immunodrugs. Thank you. I choose 3. Okay, thank you. The dual immunotherapy also has a very big side effects. So for this patient, now is transferred to the cancerology center of Fudan. You see that the TMB 3.4, not really high, but PDL1 for TPS and CPS is quite high. So at this stage, he used pozopamdib and PDL1 inhibitor. So there's a complete switch in both targeted therapy and immunotherapy. So. So you see that it's changed to pazopanib and PDL1 inhibitor. 2 months later, so you see that multiple soft tissue nodules with enhancement were found in the left abdominal cavity, and also significantly smaller than before at both the left abdominal wall. So you see that there were a lot of tissue nodules before, but after treatment they have shrunk. So in only 3 months, and also at the abdominal wall, the cavity, the nodules has shrunk. So with this treatment, it has maintained this treatment, and in August 2023 and in November 2023, the lesions have been reduced, less obvious than before.
Then in October 2024, so 1 year has gone by, we can see that the effect is still very good. We can see that the nodules are not very obvious, and the small nodules in the liver have become smaller. So the result is PR. So 3rd line therapy is so effective. It's a very good result. The side effect, proteinuria, it's a very common side effect of TKI. This is not controllable, but there's no other adverse reactions. So after the surgery, we used pembrolizumab and axitinib, and then pazopanib, and then after 3 months, PD. And then we changed everything. We used pazopanib, and then after 19 months, PR. So the third-line treatment has been very effective. From this case, we can see that for advanced liver cancer treatment, we need to be very flexible. The target and the immunotherapy can both be replaced. Also, gene testing can play a very important role in guiding clinical research. Thank you very much. And please take your seat. Now let's come to the next part. Let's invite our moderators Guo Jianming, Xue Jianyi, Yang Guosheng, Gu Jiang, Xiao Kefeng, Wang Xiaoling. Professors, please come to the stage.
Next, we will go into the session on the optimization of drug treatment strategies. I'll be co-moderating with 5 experts. I want to be dwelling on the backgrounds and information of these experts. Without further ado, I will invite the first expert to the stage, Professor He, evidence-based research leading to new breakthroughs in immunotherapy for UC. Thank you very much for your kind remarks. Ladies and gentlemen, colleagues, good afternoon. I wish to present to you the new research outcomes or recent research progress in immunotherapy for UC. Previously, we already talked about how patients in renal cancer has used CI for many times, from chemotherapy all the way to the targeted therapy. Now we are entering into immunotherapy era. The immunotherapy era actually started by UC, PD-1, PD-L1, CTLA-4. All these new evolutions have been happening in UC treatment because chemotherapy has been dominating in UC for too long. After the inception of these new immunotherapies with more and more evidence indicating its efficacy, we have seen that FDA and MPA have all approved ICI drugs. These are the ICI drugs approved. Domestically, these are the ICI approved, but domestically, not a lot of drugs are approved for UC. So I won't be dwelling on the names. I believe you're all very familiar with these ICI drugs. PD-L1, a drug used by the previous renal cancer patient. What drug is that? We were all guessing. So for different ICIs, what about the efficacy difference? There's no very convincing comparison, but if you look at the pharmacodynamics, you will see that various ICI drugs have a different efficacy for the different receptor occupancy, or steady state. There are slight differences between these choices. Nivolumab, for example, for PD-1 receptor occupancy, there is quite a long effective period. And with a very small dose from 0.3 all the way to 10 milligrams, you will see that it achieves equilibrium very fast, and the steady state is quite long. So that's why nivolumab can become a very important treatment choice. And for all these ICI, and if you look at the IgG4, IgG1, only nivolumab and durvalumab have so you see that these antigens will reduce the specificity of these immunosystems. So nivolumab and durvalumab have the best low specificity. So since 2016 and from first-line treatment to second-line treatment and all the way to neoadjuvant treatment and adjuvant treatment, the ICI has been changing. Immunotherapies have been reshaping the treatment landscape of UC. From the very start, PD-1, PD-L1 in second-line treatment of UC have all seen certain outcomes, but if you look at the first-line and adjuvant treatments, the possible outcomes become less and less because you need to have evidence-based on second-line treatment. There's only phase 2 trials. There are 2 domestic drugs that are dominating the landscape. They have been playing a very important role. But if you look at first-line and adjuvant treatment, which need phase 3 trials with end-to-end comparison, PD-1, PD-L1 inhibitors, they don't see a lot of outcomes currently. So for UC immunotherapy, what kind of evidence-based journey of immunotherapy of MIUC? Let's first look at the adjuvant immunotherapy. In clinical settings, we use it in perioperative stages and first-line treatment. And for second line, not a lot of patients can use that. And currently, we have 3 trials: azulimumab and also pembrolizumab and also nivolumab. So these are high-risk patients, and the endpoint is PFS and OS. These are the endpoints. And you first look at INVIGOR trial on atezolizumab for DFS and OS. All this is negative. These 2 curves are inextricably linked, so it's a failure. And for us, you will see that for pembrolizumab, the UC outcome is out, and you can see that pembrolizumab 29 months, but for control group only 14 months. So DFS has doubled. So this is a very encouraging outcome. But for OS outcomes, the 2 curves, no significant changes. So for pembrolizumab, in terms of absolute value, it's even fared worse. So is it a problem of trial design, or it's a problem with the drugs themselves? So for these trials with 2 endpoints, only 1 DFS is positive. OS is still doesn't see any positive trends. So there's still questions in this area. And for Checkmate 274 is for adjuvant treatment, and this is the only one DFS and OS endpoints both achieved. So for this, you are all very familiar with this trial. The patients included who have received a neoadjuvant chemotherapy, and also for the 2 groups, you have nivolumab IV every 2 weeks and placebo IV every 2 weeks. So you see that the PD-L1 higher than 1% and DFS in the ITT population and randomized patients with all tumors with PD-L1. So you see that DFS 22 months versus so it's a doubling effect, doubling the benefit. But if you look at the PD-L1 positive patients, so it's even higher, 52.6 months versus 8.4 months, times the benefit. So for PL1 positive patients, they have even bigger benefits, and the OS is even 20 months longer. So this is for whole population, but for PDL1 positive, its death rate has reduced by 44%. For overall population, so you see that for PDL1 positive population, OS has even higher benefits. So for these three categories of drugs and with 3 trials, you have different outcomes. From these statistics, that's why nivolumab is recommended by guidelines as NIPA has approved nivolumab. So this is adjuvant treatment. And now let's look at first-line treatment. As you may well know, the chemotherapy has been dominating the UC treatment for over 30 years. For advanced UC, we haven't seen any progress in treatment tools, and it's been a headache for all of us. But now we have an immunotherapy inception and also other combined therapies. So for advanced UC, the landscape has completely been disrupted. For the Checkmate 901, it achieved the first breakthrough in first-line immunotherapy combined with chemotherapy for UC in 30 years. So with the ICI advent, so a lot of people are doing immunotherapy combined with chemotherapy. So Vega 130, Danube, Keynote 361, and also the Checkmate 901, which is our focus today. So for Invega 130, atezolizumab plus platinum chemotherapy as first-line treatment for advanced UC, you will see that the 2 curves of OC, they are linked, and you see that the side effect is that the maintenance therapy can have good outcomes and prognostics. For Danube study, durvalumab alone, nor the combination of durvalumab and durvalumab combined therapy, they haven't reached the endpoints. But for Keynote 301, a lot of people have been looking forward to that, and you will see that the PFS curves have been quite different, and you will see that it's 8.3 versus 7.1 months, respectively, and the OS is 17 versus 14.3 months. So they haven't achieved the preconditions of endpoints. So the curves have there are certain differences between these 2 curves, but the endpoints have not been achieved. And for Checkmate 901, so it's a combination therapy. Nivolumab and gemcitabine versus gemcitabine and cisplatin. So it's then there's a monotherapy phase, which changes the dose after 3 weeks. With the drug resistance, the treatment of nivolumab will reach a period of 24 months, up to 24 months. So when we're talking about the bladder case, a lot of people say that 1 year is more than enough for the treatment, but I believe that the answer is 2 years. So for the Checkmate 901, the PFS and OS have seen statistically significant differences, and compared with the single chemotherapy, the median OS has reduced by 28%, the reduced risk of progression or death by 28%, and the reduced risk of death by 22%. So the 2 curves have been quite distant from each other. So the 2 trials have achieved the endpoint endpoints. The two primary endpoints have been met. And also in ASCO conference in this year, the lymph node positive patients have been highlighted, and you will see that their median OS has reached 46.3 months, approximately 4 years. So for whole population benefits, and for the LN patients only, you will see that the combined therapy has better performance. Now for summary, there are 4 chemotherapy plus ICI therapies treatment. These 4 trials. Only Checkmate 901 has achieved results, and nivolumab plus chemotherapy. All the other 3 have failed. There are multiple reasons behind that. It's quite complicated. I won't dwell on that. But for nivolumab plus chemotherapy, its success have given us more inspirations in clinical settings. And based on the Checkmate 901 outcomes, FBA, MPA, the National Drug Administration have all approved nivolumab in the adjuvant treatment, and also it has become a first-line treatment for combined therapy for UC, and this has opened up new perspectives for UC treatment, be it first-line, second-line, or an adjuvant treatment. The nivolumab has good performances. I believe that in neoadjuvant treatment, it will have even better performances. So clinical patients will have more choices and more benefits from these drugs. Thank you.
Thank you, Professor, for your excellent presentation. Thank you for talking about 901 and first-line research and other treatment. You talked about how people can benefit from this, and this can guide our clinical research. Thank you. Next, our next speaker is Xiao Jun, who will talk about thinking about the strategy of endocrine therapy for prostate cancer. Dear colleagues and chairman of the conference, good afternoon. Today, I want to talk about the strategy of endocrine therapy for prostate cancer. First, I want to talk about combining PSA and testosterone monitoring to build standardized ADT for PCA. Currently, we have the dilemma of testosterone monitoring. First, so what is the standard, 20 or 50 ng per dl? For clinical doctors, this is still a question. And also, the test results of testosterone are different. We need to have the common standards. And the relationship between testosterone and the PSA levels is not linear. Lastly, testosterone monitoring and test results are not reliable. So if it's bigger than 20, then we lack consensus on follow-up treatment. This comes from abroad. This is a survey of 153 doctors. It shows that many doctors have no consensus on the frequency of testosterone tests. And also, they do not understand the testing methods of their hospitals. And they actually don't pay enough attention to the test results. Now, guidelines in China and abroad adopt 20. Less than 20 is the appropriate castration level. We know that lower serum testosterone levels during ADT are associated with lower risk of death and progression. From literatures, we can see that compared with the standard of 50, if the level is less than 20, then in terms of lowering biochemical metastasis, and also CRPC and OR. I think the lower the level of testosterone, the greater advantages the treatment has. In most hospitals, we use this approach to test testosterone, but different machines have results that are not comparable. Also, in terms of targetedness and sensitivity, we cannot be very sensitive to low level or high levels of testosterone. We need to be more precise. But some approaches are very expensive, so they require a lot of investment. So many hospitals haven't adopted the advanced approaches. So if the radioimmunoassays that are not good enough, we use spectrometry. Research shows that testosterone levels, let's look at the left. Testosterone levels do not have a linear relationship with PSO levels. So in the first year of ADT, the PSA progression is not affected by testosterone levels. During ADT, we still need to monitor testosterone, and also during the ADT period, we need to monitor the movement or the change of testosterone during ADT and the CRPC, and during the entire stage of ADT, we need to monitor testosterone change. This summarizes that when testosterone is less than 20, when PSA is less than 2, then we can have different combinations. So under different conditions, we need to do the corresponding treatment decisions. This is a very detailed analysis. So should we continue ADT or should we add some anti-inflammation drugs or anti-androgenic drugs? It's very detailed. Next, I'll talk about MHSPC. Should we use combination therapy? We should have more evidence-based therapies. In the past 10 years, different drugs have been invented. Now we have more treatment choices. In the past, we only had 1 or 2 drugs, not very much choice. Now we have a lot of new drugs. And also, pharmaceutical companies from China and abroad have invested a lot. Doctors keep learning, keep making new combinations. We have some very individualized treatment. Meta-analysis shows that ADT plus novel endocrine drugs or docetaxel is superior to ADT in terms of survival or failure-free survival. Enzymet, PEACE, Aracin. The 3 researchers studies ADT plus docetaxel plus a new drug, enzalutamide or abiraterone. For MHSPC, is there very good benefits? Research shows that in high-burden metastatic prostate cancer, compared with the double therapy, the researchers shows that the triple therapy improves the patient's progression-free survival and overall survival. For patients with low tumor burden, can they limit from the triple therapy with docetaxel? There is limited benefit. And CHAPI and the standard research shows that compared with ADT, the combination therapy can improve MHSPC survival, but only with high-load patients. For low load patients, ADT plus doxatesamol is not significantly different in terms of OS. So for MHSPC, ADT plus a drug is still recommended by the guideline. There are patients that originally need ADT plus doxatesamol, so triple therapy is a viable option, but the benefits remain questionable. In the 2024 EAU, there is a study, a real-world study. In a meta-analysis, they have over 6,000 patients, 8 RCTs. They want to classify different loads. They want to test the benefit of the triple therapy. And also they compare the triple therapy with the double therapy. In terms of OS, triple therapy for high load patients compared with the low burden HSPC. The patients will do better compared with double therapy with ADT plus doxatesamol. ADT plus, or for low, in terms of OS, there is not significant differences. So you can see a ranking here. We know that ADT plus doxatesamol can change the OS of high-load patients. Enzalutamide plus ADT work best for low-load patients, low-burden patients. In Cisco guidelines, low-burden patients need ADT, and the other two drugs. Chartered, Stampede, or Arison researchers show that also we have the consensus from CPCC. They all recommend that for different tumor burdens, for different risks, we should have different combination therapies and individualized therapies so that prostate cancer will be better treated. This is the trend. This research also shows we have also a separate research, PISMA PET. So we can use new image. They are better compared with traditional imaging in testing metastasis. Also, PISMA PET is less radioactive compared with normal CT scans. According to the 2022 EAU guideline, through PSMA test, we can show that for high-risk patients in the initial stage, we need to have more sensitive approaches compared with the bone scanning, but without forward-looking to show the benefit in survival. PISMA PET can be more sensitive, but the result is unknown in terms of its prognosis. Still, we don't know whether through PET-CT and MRI, and then we find the metastasis. Should we have the whole body treatment? Or should the patients receive a local and metastatic treatment? So we have these new and very sensitive images. They can find the metastasis, but should we intervene? Is there overtreatment, or does it cause anxiety of the patients? MHSPC's future trend. We need early active treatment. Also, we need combination therapy. For doctors, we need to pay attention to the quality of life of the patients and explore gene testing. For MHSPC patients, PM50 analysis. PM50 detection is different from previous distribution characteristics based on local prostate cancer. and luminal B cell proliferation. Active luminal B cell proliferation signal pathways benefit more significantly from docetaxel treatment. So molecular and gene analysis is very important to individualize the treatment. Also, we need to have standardized follow-ups. We shouldn't only focus on treatment. We cannot ignore the follow-ups. Lastly, I want to talk about ADT drug selection and AE management. Now we use a lot gene RH. It has this so-called ignition effect or flare effect, so it may cause cardiovascular adverse effects. We have this new GnRH inhibitor. It will not cause increase in testosterone. It will not cause flares. It will reduce the incidence of cardiovascular events. But use this thing early will have some other effects. It may cause maybe serious side effects compared with the ADT alone. ADT-based combination therapies include all kinds of second-generation anti-androgen drugs and chemo and immunotherapies and targeted therapies. We have multiple drugs, multiple treatment methods. If we integrate them, they will also bring adverse effects. So we need to take these seriously. Overall, compared with the ADT alone, ADT combination therapy may increase the side effects whether you use abiraterone or enzalutamide. So it will cause high blood pressure, cardiovascular events. So overall, compared with ADT plus docetaxel, if we use the triple therapy, the adverse effects are more. They include high blood pressure, fatigue, and also the decrease of some cells. With new drugs and the lengthening of the treatment period of time, the testosterone levels are reduced. They may cause osteoporosis, some also diabetes and other situations, also anemia. So these are the major causes of non-cancer deaths. They don't die from prostate cancer, they die from the long-term use of such drugs. So we must take them seriously. Comprehensively speaking, GnRH has some adverse effects. They may cause some problems and affect people's health, and they may cause reduced compliance and reduced prognosis. If we have a muscle shrinking, also some metabolic diseases, or if we have hot flashes or anemia, we can change the doses, and they can have very good effects. They can reduce adverse events. Also, moderate exercise can reduce ADT-related adverse effects. Thank you.
Thank you very much, Professor Xiaojun, for the endocrine therapies for prostate cancer treatment. Within such a short period of time, you give us a lot of information. So the management of testosterone and also the preventive treatment and also the combined treatment in endocrine treatment should be more customized and individualized. Thank you very much for your ideas. Next, before Professor Dai Bo's speech, I wish to share with you some observations. The team led by Chairman Ye and Professor Dai didn't start very early because I came here from Guangdong. I participated in 5 editions of this event. I am a witness and also a participant of this event. The bladder cancer number has 7,000. And a lot of drug validation, a lot of guidelines have been benchmarking against their experiences. 5 years after I came to Shanghai, Chairman Ye is also the GUCA chairman member. I'm the permanent member. He is the CAG-GEO chair member. I am a permanent member of this association. I participated in a lot of conferences held by the association. When we walk together, we walk farther, and when we walk alone, we walk faster. So a lot of leading experts here present have done a great job in collaborative efforts. We walk longer and farther when we walk together. So this is something that I wish to share with you. Next, I will give the floor to Professor Dai Bo to talk about the history and development of endocrine therapy for prostate cancer. Thank you very much, Chair Yang, for your kind remarks and introduction. I will talk about the development of endocrine therapy for prostate cancer. So for endocrine therapies in China, in 1995, these endocrine therapies first entered Chinese market, and after 10 years, in 2005, endocrine therapy drugs have been widely used. And between 2006 and 2018, ADT drugs represented by GNIJ gradually replaced surgical castration therapies. The majority of hospitals, they won't do surgical castration therapy anymore. And 5 years later, the endocrine therapies have been widely used in various stages of prostate cancer treatment. In 2024, ADT has become the most important SOC in MPC and is used in combined treatment also. First, I will talk about the early diagnosis and treatment system in China of prostate cancer. So this is the whole evolution of prostate cancer treatment therapies. And as the timeline draws nearer, you will see more and more new drugs launched into the market, not like 1 century ago. The treatment tools were very limited. The dissection of prostate and also the first-line drugs, and a lot of targets were being developed to treat prostate cancer treatment, which has extended the survival time. And surgical castration, as we highlighted before, it has many downsides. For example, they will affect the quality of life of patients, and it's not reversible. Once you're castrated, it cannot be reversed, and it will be permanent, and it cannot use hormone therapies. It cannot use intermittent endocrine therapy. But for medical castration, there's no such damages. For example, the GnRH and agonists, the main drugs for medical castration, the OS and the is quite good. And in 1980, the prostate cancer incidence increased. The mortality rate has been decreased. The OS has been increased, and after 1990, with popularization of PSA screening and the application of GHRHA, and the mortality rate of prostate cancer in the US has declined, and the mortality rate overall has decreased by 37%. Next, we will talk about the deepening presence of endocrine therapy for prostate cancer. So this chart has shown shown that there are different treatment for different stages of prostate cancer. For low risk and moderate patients, you can use surgical radiotherapy, and you can observe them and wait it out. And this is standardized treatment. And then for moderate and high risk, and then for MHPC, for biochemical recurrence, for CRPC, for mCRPC, etc., the baseline treatment is the medical castration, ADT, GnRH drugs. So all these will play a very important role in these stages. You can use anti-estrogen drugs or first generation drugs. Compared with the medical castration, we have found that if one drug is used alone, its efficacy is not as good as a combined therapy with medical castration drugs. So medical castration is the baseline treatment and the foundation for treatment in various stages of prostate cancer. Goserelin is a long-term medical castration drug. It's been used in 30 years plus, and a lot of trials have reported 10 plus years of overall survival rate. And EORTC, RTOG, all these are radiotherapy trials, and the median follow-up has 9 plus years and a 10-year OS rate. Compared with radiotherapy alone, you will see that the 10-year OS rate, the 10-year DFS rate have been lengthened. But for localized advanced patients, Goserelin have also shown efficacy in various trials in terms of benefits of OS, SWOG, ECOG, GCOG. GTOG is also a European trial led by French experts. You can all observe that the 10-year OS rate has seen improvements. And for biochemical recurrence patients, the GTOG-16 trial is representative. At that time, it has changed the clinical practices landscape. For biochemical recurrence patients, if in their body there's no clear lesion, then you can do salvage radiotherapy. But if you compare that with 6 months of Goserelin addition, then you will see that after 10 years of follow-up visit, the PFS rate and MFS rate for both of these patients have shown significant improvement. So for these biochemical recurrence patients, if you use imaging and you don't see any metastasis lesions, and you can use 6 months of endocrine therapies, Goserelin for 6 months, then you will see benefits of PFS and MFS. So for PISMA, this has shown that a lot of there are some mini metastases. So radiotherapy alone will not have good effects. These mini lesions have caused the progression of the disease. So these trials have shown this outcome. And for EORTC trial have also compared with Goserelin versus the dissection of the. So you will see that with the flutamide, currently, we don't consider flutamide anymore, but it has a historical role. So the outcome was published in New England, and it has also shown the evidence pointing to OS improvement, but now it's been phased out, and now we have Gen 2 drugs that have emerged. So you will see that the Goserelin implants can effectively reduce testosterone and PSA. And so this has confirmed in China that Goserelin implant of 10.8 milligram can effectively reduce testosterone and PSA levels to a low level and at a very fast pace. So this trial, this study has shown the long-term efficacy of gosrelin implants. Next, we will be talking about creating the future, exploring innovative developments in prostate cancer treatment. So for localized, advanced, or high-risk prostate cancer patients, there are combined use of different tools. For example, surgical radiotherapy and also the endocrine therapies. A lot of patients can achieve a longer life expectancy, but for metastatic PC, MCRPC, MHSPC. For MSHPC, the incidence is very high, survival rate is low, and efficacy is quite low. And there's a demand for individualized treatment. For MCRPC patients, it's now at a later stage of the disease, so poor prognosis, resistance of drugs, and lack of a sequence of treatment and lack of biomarkers to choose the best treatment tools, because there's a wide array of treatment tools, so there's no biomarkers to predict which drug will have the best efficacy. So currently, the development level of drugs, so we're going through a more precision-based and multi-targets path, targeting AR signaling, bone, microbone, PAMA, P13K, AKT, mTOR, immuno checkpoints, cell cycle, etc., epigenetic markers, etc. So AKT inhibitor brings new hope for the treatment of newly diagnosed MHSPC patients. So for AKT inhibitor, the population is EI gene, PTI gene deficient patients, because it's not active, so this path will be activated, and the tumor suppressor gene, PT gene, has seen efficacy in MFS. Now we are promoting this drug to MHSPC patients. MSPC patients, if you can see that there are mutations, and for P10 with good functions, then the survival rate will be better than P10 mutation patients, because the AKT pathway has been activated. If there's a P10 defect and both genes are defected, then the prognosis is the worst. This has shown that the P10, this cellular marker, is a very independent signal for prognosis. So if you use the P10 in the treatment of the patients, then you will see that if there is a P10 defect, then if they use the AKT inhibitor, if the survival rate can be lengthened, then this has shown that the P10 is not only an element for prognosis, but also a prediction signal. And the main difference is that if it's a predictor, then you can predict whether its efficacy is effective or not. If P10 is not only associated with prognosis, but if it can also indicate that AKT inhibitor can be used in treatment, then it's very important. So in trial 1, phase 1 of AKT inhibitor, you can see that the 15 patients have seen their PSA decline. So in 3 of the 15 patients, they use 3 months of ADT. They can add Abitrol or without Abitrol. So ADT plus Abitrol plus AKT inhibitor. So the primary endpoint is PFS, and the secondary endpoint is OS. Why PFS? Because in terms of prostate cancer, there are too many drugs. For first-line treatment, if you want to achieve OS, prolong the OS is too hard. For the doxitacin, it's very hard. So if you do the same repetitive experimentations, you might not achieve this endpoint. So PFS has become very widely accepted and internationally recognized by FDA, for example, endpoint. And also the PARP inhibitor. So it's a combination of combination of drugs for MHSPC patients. For these patients that has HRR mutations, the prognostics will be worse because HRR mutations, be it BRCA1, BRCA2, the prognostics will be worse. But that's for prognostics. But if your research can find that PARP inhibitors can change the can improve the OS of these patients. It can also be seen as a predictor factor. Now, with the MHSPC treatment, we subject all these patients to gene testing. One is with a HR mutation, the other is without. So the standardized treatment is ADT plus second-generation anti-androgen drugs. So these two groups have been compared, the HRRM and the non-HRRM. And then with the HRRM mutation patients, have reached the endpoints. But if a non-HRM patients can also achieve these two endpoints, then this will be seen as a great progress. And we're also exploring new pathways, for example, antagonists and AR degradation with PROTACs. So to summarize, GNI drugs have been breaking the deadlocks in prostate cancer treatment. It has become the foundation of the prostate cancer treatment. And also with gene testing and new technologies, we can apply more customized and individualized treatment for patients.
Thank you. I'm deeply impressed. He talked about two very important things. First, consistent. We know that endocrine technology, we have been doing this for over 100 years. So that's not easy to achieve. In 2005, I began to learn this for the first time, and now we still use the same approach, but I've grown old. It means that the treatment is very endurable. And also, all kinds of inhibitors, all kinds of new generation endocrine drugs have been launched. It's just like in the Sui and the Tang dynasties in China. At that time, many people came to the forefront of history, and now we also have a lot of drugs. We have AKT inhibitors and other inhibitors. They are in use. We believe that the new things will be something that can bring consistent benefits. Thank you, Professor. Our next speaker is from the host institution, Professor Zhu Yue, who will talk about new progress of PSMA-targeted radiogland therapy. I want to thank the moderator, dear experts and colleagues. Good afternoon. I want to talk about some applications of PSMA-targeted radiogland therapy. PSMA is prostate-specific membrane antigen. It's a kind of thing that can bring integrated treatment and diagnosis tools. For example, we have this plus 68, the PMA. Through PET-CT, we can spot the 60GA to spot the metastasis and expansion. And also, we use the radiogland therapy such as Lu-177. We bring it to the tumor position to have alpha or beta particles to cut the DNA and to kill the cells and to kill the prostate cancer. This is a very good future trend. 177 Lu, PSMA 617. now is backed by a lot of evidence. It has the following features. It has the PSMA 6-1 ligand. It has a very good radiation radius and half-life, which can kill tumor cells. Also, it's very targeted. It can target the bones, lymph nodes, and the soft tissues. It has great potential in the future. Its advantages are based on the high expression of CRPC. It has very good penetration, and its toxicity in the blood is very small. Its half-life is 6.6 days, moderate treatment time window, and it's safe and effective. And today, I want to talk about some progress in the targeted treatment, the management pathways, and the new breakthroughs. The first progress, PSMA in 2014 began some clinical studies and has attracted attention. Over the past 10 years, we had a surge in PSMA research in different targets, FAR-P, PSMA. So this is like a blockbuster molecule. It has attracted 63 researchers, so it's a very hard field. In different stages of prostate cancer, PSMA treatments can be leveraged. In Vision study in late stage, in front line, 19101 research to the PSMA addition, and also neoadjuvant study, which Dr. Murphy talked about. You can see there's a lot of PSMA-related research, and in many international conferences, it has become a hotspot issue. It shows that PSMA-targeted RLT has become a very important treatment method. Let's look at the clinical management. When prostate cancer goes from limited to metastatic to resistant to hormones, there are different treatment models. Let's look at the Vision study. It's the first phase 3 clinical study in the treatment of mCRPC after chemotherapy. So it is used when some drugs are no longer effective. We have two random groups, and there's one group that is using standard treatment. We look at RPS and FS. Let's look at this study. This is a phase 3 study. It has very good OS, overall survival benefit. The overall survival has been lengthened from 11 to 15.3 months, and the mortality rate is down. And in terms of imaging, 60% down. So this can be a very important criterion. PFS needs to be improved by 60%. Then OS can have a good result. PSA remission is very good. PSA 8, 33%. Objective response rate 51. Symptoms, very good improvement. How can we do an improvement of vision? First, we look at the SUV expression of this. We know that this is a kind of precise treatment. You need to look at the PSMA PET results, and you exclude patients that do not express PSMA and then include them in the group. As the SUV goes up, the median RPFS and OS are significantly longer. For example, SUV mean, if it's over 10, then the OS is 21 months, RPFS 14 months, so it's a significant improvement. Now let's look at the correlation. Correlation is very good between RPFS and OS. These are very important data. We've seen a lot of such research. RPFS has benefit, but OS does not benefit. In terms of dose security, We know that renal toxicity is a very important issue. There is no very strong renal toxicity. It shows that the 6 cycles of the drug administration has been very safe. Let's look at some new breakthroughs. A very important thing is the frontline PSMA4 research. PSMA4 is a stage 3 global study. Let's look at some of the key aspects. First, it's about patients that have endocrine some treatment, HSPC greater than 12 months. Patients receive chemo and they are positive after PSMA PET scan. Negative patients are excluded. And after treatment, there are 2 groups. One 177 Lu PSMA 617. The other is another endocrine drug. It's very interesting. It allows cross treatment. It means that if one treatment is not effective, you can switch to the other group. For example, you can go to the Lu 177 group. RPFS is a major endpoint. OS is the secondary endpoint. Let's look at the RPFS. And its advantage is very clear. It went down by 57%. As I said, it's very similar to the 60% drop. It means that Lu 177 at different stages of CRPC can have very good benefits. Its RPFS goes from 5.59 months. I think if we switch the endocrine drug, the effect is not very good. So within half a year, some patients will have progression. If we use Lu 177, the time is 1 year. And also, let's look at the subgroups and their RPFS. So if they use Lu 177, they can benefit. It means that in most groups, they can benefit from this treatment. Let's look at another very important indicator. The remission or ORR or other aspects, the improvement can be 57% instead of 20%. The response is more than 50%. It's much better than the 20% in the other group. So these are very key data. If we design clinical studies, we need to consider that maybe there's only a 20% response, and RPS may be less than a year. But if you use Lu 177, then 50% of PFA response, and the ratio is 57.6%. RPF is almost 1 year. It's a very big advantage. Let's look at past history of endocrine therapy. Still, in terms of RPFS, it's very good. If you have used abiraterone or enzalutamide, you can almost extend your RPFS by 12 months, and PSA 50 can reach 64.2 and 51.7. If you switch to a new endocrine drug, if you have received enzalutamide, then the response is very low, only 12%. If you have used abiraterone and you switch to enzalutamide, then it's 25.6%. So it's a very big difference and something we need to focus on. And objective response rate, 61% and 40%. In the control group, if they switch, the numbers are only 16 and 13%, so very bad numbers. Let's look at MZOP 1901. It comes from Australia. In PSMA, they have done a lot of research. So in terms of inclusion criteria, the patients must have high tolerance of the failure of enzalutamide. They are very likely to have resistance, and we have the enzalutamide group and also the other group. We look at the PFS. In the enzalutamide, it's 7.8 months. In the other group, in the Lu 177 group, it's more than 17 months, so it's better than 1 year. So there is a significant improvement. The risk goes down by 57%, close to 60% drop. PSA 90 goes from 37 to 78. It's a very good number. Let's look at the imaging. The advantages of the radionuclide treatment. You can see the progress. If this is the baseline, if there's so much metastasis, if you use enzalutamide, then the area is actually increasing from 1,400 to 1,700. SUV goes from 75 to 102. SUV mean goes from 8.5 to 10.3. It's a very even increase. If you use enzalutamide plus Lu 177, then there is high expression and PSMA goes from 1,000 to 300. SUV also drops dramatically. So enzalutamide and Lu 177 can be very helpful. The SUV can be higher, the effect is more obvious. In the CRPC patients, if you use enzalutamide, you can see that 70% of the patients have increasing SUV max. The ratio is very high. The mean increase is 29. 40% of the patients increase more than 20% SUV mean. 68% of the patients have an increase TTV. The tumor volume for 68 patients, it's an increase of TTV. So these are very high numbers. We can see that for SUV max and SUV mean, in patients with these elevated levels, enzalutamide plus 177 Lu PSMA have greater advantages. This is very important. Through enzalutamide and PSMA, the SUV increases and the Lu 177 becomes more effective. Otherwise, it's not the case. So this shows that 177 Lu and the plus traditional endocrine therapy have great potential for improvement. We can have more approaches to improve the application scenarios of 177 Lu. We can use endocrine therapy to increase the efficacy of the combination. In non-metastatic CRPC, there are also improvements. Also in oligometastatic, extensively metastatic, and non-metastatic, we need to focus on some combination treatments. As we have better drugs and as we become more experienced and do more clinical trials, they have very good potential. Now a summary. 177 Lu PSMA 617 is a new treatment method that binds to PSMA and to achieve targeted killing of the tumor cell. And based on the vision study, it has been approved by FDA and the EU, and it is now recommended by more guidelines. We hope that we can see this drug in China very soon and bring the drug to Chinese patients. And I also am very upbeat about the multi-center study of 177 Lu so that it can benefit more patients. Thank you.
Thank you very much, Professor Zhu, for your very inspired presentation with PISMA as a target. This treatment has been used in various scenarios of prostate cancer, which has brought about a lot of benefits in terms of OS and quality of life for these patients. Thank you again. So now I conclude this session with a brief summary in terms of we have a lot of good discussions for PISMA target gland therapies, the endocrine therapies, and also treatment for UC. Due to time constraints, I won't have a very extensive comments, so I conclude this morning's session. We will have a forum